Hi, I'm Tom Oakler. Welcome to this Muscle Energy DVD. I would just like to let you know I've been practicing physical therapy since 1978, and I've been doing muscle energy and manual therapy since 1985. Before we get started, there's some important information I want to give you about the background of muscle energy, and this will help you in your muscle energy careers as you go on. Two very important key phrases. One is bone is the slave of muscle. Bones cannot work, they cannot act, they cannot do anything unless a muscle directs them to do so. And when bones get out of place, subluxed, whatever you want to call it, they do so because of the muscles and not from anything else. So in order to correct the dysfunction, the somatic dysfunction, you need to correct those muscles, and in particular the muscle spindles. And we'll talk about that more as the DVD goes on. The second thing I want to make you completely aware of is with osteopathy in general, and especially with muscle energy, you use maximum precision and minimum force. So as opposed to doing something which just kind of shotguns the body, we're going to be very precise here, but we're going to use hardly any force when we do it, and you'll be absolutely amazed when you see the results you're going to get. Okay, the first big question, what is muscle energy? And by definition, muscle energy is a direct technique which uses the body's own subtle energies, and by energies, I'm talking about nerve energies, nerve connections, to correct tone in a muscle. In other words, if a muscle has too much tone, it's going to pull harder. It will actually pull the bone into a less than optimal position and prevent the joint from moving the way it was supposed to move. And that's basically a broad definition of what muscle energy is. What we're going to do is take a dysfunctional joint that's hypomobile. We're going to find out which muscle is causing the dysfunction, and then we're going to affect that muscle so it lets the joint behave normally. And that's basically what muscle energy really is. Now, what does it really do? Well, it relaxes hypertonic and spastic muscles, large ones and small ones. You mobilize a restricted joint. By releasing that muscle, you actually mobilize the joint. The joint becomes able to move again better than it could before. You strengthen muscles which have been inhibited or are maybe getting weak. You actually reduce local edema, because if a muscle's been all tense and tightened up like that for a long time, it's not getting normal blood flow. So the minute the muscle relaxes like this, sometimes people say, I feel like I got warmth trickling down that part of my body. And in fact, that's what's happening. Blood's getting into an area that it couldn't get into before because it was so congested. So it will reduce edema in those areas. And lastly, it actually stretches muscles, fascias, and ligaments, because now that part of the body can go to places it hasn't been able to go to for quite some time. Now, how does it work? That's everybody's question. What magical mystery is going on here to make it work? It's really not that mysterious. You're actually taking muscle spindles and taking the muscle spindles back to what we call factory settings. Muscle spindles, as we'll talk about in just a little bit, have a great deal of ability to modify tone, modify tension, length-tension relationships for performing a multitude of tasks. And they work beautifully most of the time, but every once in a while, like after a slip or a fall or overuse or way too much work in a certain area or accidents or whatever, these muscles get programmed to be short, tight, sensitive. And when they're programmed to be short, tight, and sensitive, they cannot release themselves. They cannot go back. And you can do just about anything to them and give them a little bit of relief, but until you go in there and take those muscle spindles and change their mind, you're still going to have a short, tight, sensitive muscle. And you'll adapt to it, but it's not going to be comfortable. All right, so that's really how it works. Now, the goal of muscle energy, and I will say this many times during the DVD, is to find areas of asymmetry and hypomobility. So we're looking for things that don't move, and our clue to that is what is asymmetrical. And by doing that, we key in on the real source, the real cause, the real demon, if you will, of what's causing all these problems. Now, theories of hypomobility are many, and we're not going to get into too many of them, but people over the years have thought that the joints are stuck, that there's some mysterious sticky glue in the joint, and that's why they put their effort toward the joint. Well, they've never been able to show that there's any mysterious sticky glue in the joint when they autopsy people. So they're really not sure that that theory holds much water. But what we do know is that a synovium, okay, a little surrounding capsule, synovial capsule, every once in a while can get pinched. And when it gets pinched, what happens? It hurts. And when it hurts, what happens? The muscles go into protective spasm. So we're back to this whole idea of spasm and guarding. And in fact, the pinch of the synovium may go away, but the muscles don't know it's gone away, so they stay tight and tense and they hold it in place. And that's your job, to go in with muscle energy and release that spasm. All right? And the bottom line is everything, all of the work that was done back in the 60s and the 70s to show how muscle spindles respond to these certain activities and how they can be changed and reset is probably the main go theory right now for how we get somatic dysfunction. It's because the muscles, big and small, get their mind changed. They get their settings reset. They're taken off of their factory settings and made to be short, tight, and sensitive. And that's what we're going to do, is undo that with muscle energy. You want to make an accurate structural diagnosis. We're going to do that in this DV. Then what you want to do is position the patient comfortably, because if the patient's not comfortable, they're never going to relax those muscles. You're never going to change the muscle spindle's mind. You have to change its mind. You have to reset it back to its factory settings. If the patient's not in a comfortable position, it's not going to happen. The next thing you want to do is the therapist monitors the joint, the specific joint where you've determined the problem is. When you monitor that joint, you then move that joint into the position it needs to go in but can't. You approach it until you hit something called a barrier, which I'll tell you about in just a minute. You take up the barrier in all three planes wherever possible. So you're going to take up an extension flexion barrier, you're going to take up a side bending barrier, you're going to take up a rotational barrier. And you do all of those barriers, and then you ask for a 1 pound contraction of the muscle. This is a real advance over the rudimentary and more primitive forms of muscle energy, which usually only did one plane of motion. So regardless of which muscle is misbehaving, by taking all three of those barriers up, as you'll see in the other parts of the DVD, when you take all three of those barriers up, you're actually going to fix no matter what was the matter, and you don't have to sit there and worry about, well, I wonder which muscle was really causing it. You're going to fix it by putting them in that 3-barrier position. Okay? Now, the therapist requests a very slight muscle contraction, maybe a pound if we're doing articular work, and then holds it for 8 to 10 seconds and then gets the patient to completely relax and take a nice deep breath. And the therapist can breathe right along with them. It'll be a just like that. Everybody needs that. That's a good thing. That gives you the 2.5 to 3 seconds to reset the muscle spindle. And guess what? The higher centers of your brain, which very much like we see in yoga and deep breathing and meditation, that actually goes down the spinal cord and goes to that muscle spindle and actually resets the muscle spindle. So it's assisting in the process. So it's really a nice help to go along with it. Okay? After that, the therapist repositions those 3 new barriers now, asks for that muscle contraction again for 8 to 10 seconds, stops that, deep breath, and repeats that 4 to 5 times, and then always go back and check to make sure that the dysfunction you went to fix is now fixed. A muscle barrier is the first hint, the first inkling that you've caused the bone to move with your motion, and or tightness in the tissue. So if you're moving a hip and all of a sudden you feel the hip bind up, or you feel the bone that you're palpating move, either of those is a barrier. And what you do is you want to back off of that barrier ever so slightly. You hit the barrier, you back off. You hit the barrier, you back off. That's for your articular work. When we're working with the SI, when we're working for the IS, when we're working the lumbar spine, thoracic spine, it doesn't matter. Those are those barriers. You bang into them and then you back off. Now I'm going to contrast that with when we treat muscles, because there's 2 types of muscle energy. There's the articular muscle energy I was just speaking of, and now there's muscle energy. And now you're saying, oh, wait a minute, I'm getting confused. No, wait a minute. When you treat a muscle like the upper trapezius or the quadriceps or the glutes. They're large muscles. Sometimes you can make tremendous improvement in the patient's overall well-being just by going after the large muscles and doing muscle energy on them. It's not quite as specific as the articular, but as you can imagine, you need to be real specific with little bitty joints. With these big muscles, you don't have to be quite as specific. So what we say is when we're treating muscle energy, we go to the barrier and we go a little further yet. We go a little beyond the barrier and we ask for a 20% of available muscle power. That's subjective. I understand 20% is subjective. It's more than a little bit and a lot less than kicking me to the other side of the room. So it's somewhere in between, and don't get too worried about it. It's about 20% of effort. Do the best you can. Hold that contraction for 8 to 10 seconds, relax, deep breath, and then you stretch and stretch and stretch and stretch until you feel that bone moving, or you feel that tension come on in the tissue, at which point you say, okay, there's my new barrier. I'm going to go a little bit farther, and then I'm going to contract the muscle. And you just repeat that 4 or 5 times, go back and check your muscle length. People make some errors in muscle energy, and they're quite common, and it's absolutely normal, and don't worry about it. You're still going to get some result, but the more closely you get to perfection, the better results you're going to get, and it'll happen quickly. You'll really start to feel these things quickly, and it just takes practice, okay? One of the biggest errors is that people are not monitoring the involved joint. They're literally, if there's a problem at L1 or a problem at the SI joint and they're monitoring something down in the hip, they're not going to get the proper result. If you've got a problem that's going on at the sacrum and you're monitoring up in the lumbar or thoracic spine, you're not going to get your results. You've got to be right over that spot so you can feel the barrier. Another mistake that novices make is too forceful a contraction. Remember, you need 1 pound. And the reason we ask for such a slight contraction is if the person contracts too strongly, they bring in other muscles, and those other muscles may stop the spindle from being reset. We don't want that. So really, really less is more. Maximum precision, minimum force. Too short of a muscle contraction. I like to hold the muscle contraction for 8 to 10 seconds. And now here's a clue. If you have a patient who has a neurological problem, stroke, spinal cord injury, or other neurological component to their dysfunction, or they're a long-term chronic pain person, hold that muscle contraction for 30 full seconds. And then you go on and continue to you reposition your barriers, ask for the contraction, but each time you do it for 30 seconds as opposed to 8 to 10, you get even better results with these people. Somehow the nervous system, when there's been actual involvement in the central nervous system, it reacts a little slowly, so you need to hold the contraction a little bit more, okay? If the patient doesn't completely relax, when you take your deep breath and you go to reposition, the muscle spindle's not going to change. So the patient's got to take that deep breath and completely relax while you reposition to the new barrier. That's important, okay? And if you bypass the appropriate barrier, in other words, you're doing your barriers, you're moving the legs around, you're doing all the stuff you need to do, and you're trying to impose a barrier at L5, let's say, but you go way beyond it with your movement, you're not going to get as good of a result. And we'll talk about that more when we actually do the techniques. You'll see what I'm talking about. Lastly, if you don't go back and reevaluate your work, you're never going to know if you did what you thought you were going to do. So go back, put the patient in the position, reevaluate them, and check to make sure that you in fact did correct that area of dysfunction. The good news is it is virtually impossible to do anybody any harm with muscle energy technique. As you're going to learn, you rarely use more than 1 pound. 1 pound of muscle contraction. And when you get up into the cervical spine, your contraction of your muscles is actually movement of your eyes. You can't hurt anybody moving their eyes. So usually for articular muscle energy, you're using 1 pound or less, and you're not going to do anybody any harm doing that way. There are no manipulations to be done. You'll never do one. We don't expect to hear any pops or clicks or snaps. You're actually treating the cause. You're treating the muscle which is causing this problem in the first place. You get dramatically positive results. And if nothing else, you gain an understanding of the muscle spindle and how the muscle really is the main cause of so many of our muscle dysfunctions and so many of our somatic dysfunctions as well. So that's the good news. Contraindications for muscle energy technique are you ready? Unstable fractures at the site you're treating. They could be unstable fractures from trauma or unstable fractures from pathology, in other words, a cancerous tumor. You leave them alone. That's it. If you've got somebody with a broken leg and you're working on their shoulder, no problem. You're not going to do any harm to them at all. So those are really the only contraindications you have to worry about with muscle energy technique, and they're pretty obvious contraindications. One of the things we need to do before we proceed in actually treating is determine which is your dominant eye. And the reason we do that is it determines which side of the table you're going to stand on. Your dominant eye has to be centered on the body. And if your dominant eye is your left eye, you need to be standing on the right side of the body. If your dominant eye is your right eye, you need to be standing on the left side of the body. And here's how we do it. If you'll just take your hands and put them like this and search for an object way far away from you in the room. And if you want to close it up a little bit, that's good. So right now I'm looking at the camera directly. And with both eyes open, I've got the camera completely encircled by my hands. Now if I close my left eye and the camera stays right where it was, that means I'm right eye dominant. If I close my left eye and I have to move my hands to keep the camera in view, it means that I was left eye dominant. So that's a very simple way to determine which of your eyes is your dominant eye. And that will determine what side you stand on, because you want that dominant eye over the midline. So if I'm working on a patient and I am on the right side of that table and I've got to get my right eye over the midline, I've got to come way over here to do it. Whereas if I'm standing on the correct side of the table, all I do is that, and I'm right over the midline. So determine which is your dominant eye and make sure it is directly over the midline of the patient. It's important to remember that there are two types of muscle energy. There's muscle energy, and then there's articular muscle energy. Right now, because it's a little easier to learn and still very effective at the first time you treat the patient, to do the muscle energy, but it's different from when you do articular muscle energy, and it differs in a couple of ways. One of the ways it differs is with muscle energy, you actually ask the patient for about a 20% muscle effort. And I realize that's a little subjective. It's more than kicking you to the other side of the room, but way less than just a little bitty push. So you want to have them give you a push, but only about 20% of effort is necessary. With muscle energy, you actually go beyond the barrier and do your contraction, and that differs from articular muscle energy as well. So what I'm going to do now is show you how this works, and we're going to do the muscles, the long restrictors of the muscles of the hip. And we'll be working all over these muscles in the hip, because since they attach to the pelvis, they're going to affect what I do later on when I go up and actually treat the bones, the articular parts of the pelvis. So the first one we're going to do is the hamstring. Now with the hamstring, what you want to do is first assess both sides, and we're going to lift it up like that, and I'm just going to do all the work here until I feel the anterior superior iliac spine begin to move, or some tension in the hamstrings. Either or, doesn't matter. Whichever one you hit first, that's your barrier. And what you're going to do is you're just going to go a little bit beyond that barrier and scoot up under here so you don't hurt yourself, and ask the patient to pull down into your shoulder with just about 20% of their effort. So go ahead and pull down, and you hold it. That's a little too much. That's better right there. And what you want to do is hold it for about 8 to 10 seconds. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. I like to tap the patient, say completely relax. Take a nice deep breath for me so we can reset the muscle spindle. Good, and then I'm just going to gently stretch. Now you notice I'm still palpating here, Because if I feel this move, I've hit the barrier. And I go up and I stretch and I stretch and I stretch and I stretch up, and I'm just starting to hit a barrier. So I go a little bit beyond it and I say, go ahead, push down again with about 20% of effort. She pulls down, 20% of effort, 8, 7, 6, 5, 4, 3, 2, 1. I tap her, release, deep breath. And then I stretch, stretch, stretch. And the stretch is gentle, and you shouldn't feel the palpating hand move, or you shouldn't feel a lot of tension in the hamstrings, because that means you've passed your barrier already. You hit the barrier, you do it one more time, and you repeat that 4 or 5 times until you get the amount of length that you're looking for in there. All right? So that's the hamstrings, and you would always do both sides to make sure they're equal. Next, we're going to do the adductors. The adductors are on the inside of the leg, and it's very simple. You can have the patient lie right here, but they attach to the pelvis. They attach right along the pubic bone, and because of that, you need to lengthen those guys if they've developed any spasms over the years. And as a clue to some of the other things we're going to be doing, if these muscles go into spasm, they're probably in spasm because something's not lined up at the pubic bone, but we'll do more about that later. I still palpate here at the anterior spine. I could also palpate at the pubic bone. It doesn't matter. You gently move the leg out, and you really don't have to lift it up in the air. You just slide it, and I hold it up against my leg, and all I do is I lean back until I feel that first up. There's that first hit of tension. Now, I got tension here before I got movement here. It's fine. That's my barrier. I go a little beyond it. I tap her on the inside of the leg, and I say, pull the way I'm tapping. Pull that way with about 20% of effort. That's perfect. 8, 7, 6, 5, 4, 3, 2, 1. Release it. Take a nice deep breath. As she's breathing, I'm holding her solid. I don't do any movement until after she finishes her breath and breathes normally again, and then I just gently stretch the whole time I'm monitoring. Am I feeling tension here? Am I feeling movement at the anterior superior iliac spine? Stretch, stretch, stretch. I get to a point, oh, there's my barrier right there. I can verify that by wiggling back and forth, and I go a little bit beyond it. I tap her again, 20% of effort. She contracts the adductor. She's pulling in, and hold it for 8, 7, 6, 5, 4, 3, 2, 1. And now I tap her again. Relax, nice deep breath. The breath is important because it lets the muscle spindle reset. I go and I stretch until I find my new barrier, and I repeat that again 4 to 5 times. And I would do that on both legs. If I'm going to stretch the abductor, all right, I can go to the opposite side of the table. So here I am on the opposite side of the table of her right abductor group. I pick that leg up and I keep it as close as I can to her other thigh. And all I'm going to do is palpate over here or at the pubic bone, it doesn't matter. And as I pull her across, I'll feel tension. I'll tap her here and I say, pull your leg that way. Pull it away from me. 10 pounds of pressure, or about 20% of effort. Go ahead and hold that for 8, 7, 6, 5, 4, 3, 2, 1. Release it. Take a nice deep breath for me. Let it go. Let it go. Good. And then I just go and I stretch further and further and further very gently until I run into that next little bit of tension. I go just a little farther. Tap her again. She pulls with about 20% of effort. And I'm actually supporting the leg. I'm holding this leg up so it doesn't hit the table. All her motion is going that way. 5, 4, 3, 2, 1. Release, nice deep breath. I can breathe right along with her. It helps her to breathe a good breath. And then I go ahead and do my stretch, 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 just like that. Now, supposing you run into somebody who's got some big thighs, okay? You'd literally have to pick the leg up this far and pull it over, and that may change the muscle we're working on. So in that case, what you can do is scoop under and grab both legs over, and boom, there I am. There's my barrier, and I just tap her here and say, pull that way for me, and she pulls it over that way, and that's if you got somebody who's got really big thighs. And you do the same technique. Moving on to the rotators of the hip, and this is nice in sequence because you don't have to keep flipping the patient over. If we want to do the rotators of the hip, we bring the leg up just about 90 degrees. And let's say when I did my testing, I had real limited motion going into what is actually external rotation of the femur. And I get to that, oh, there's the barrier right there. Now, I don't really have to palpate. If I want to, I can, but I feel the resistance coming out of her hip, and I go, oh, and I let her leg rest up against the side of my belly. And there's that, and I go a little farther, and I tap her right here and have her push this way for 8 to 10 seconds. So 8, 7, 6, 5, 4, 3, 2, 1. Release. Take a nice deep breath. Good. And I say, all right, let's see how much we gained. Look at, we gained all of that. Oh, there's my tension barrier again. I go a little bit beyond it, tap her on the foot. She's going to push away from me. And the rule of thumb here is the patient always pushes opposite to the way you took them. So I'm taking her this way, she pushes that way. In everything I've done, that's the way she contracts. 5, 4, 3, 2, 1, release. Nice deep breath. I support the leg the whole time. We do that 4 or 5 times. You're starting to realize how easy this is. Now, if I'm going to do the internal rotator, I move her this way up. There's a barrier right there. I go a little bit beyond it. I tap her on the ankle, and she pulls to the opposite direction. So now she's pulling this way. And again, I really don't have to go down and palpate. I could, but I can feel the tension in the hip joint itself. All right? 5, 4, 3, 2, 1. Release. Nice deep breath. And I'll do 4 or 5 of those and make sure they're symmetrical. Okay? Down you go. All right. Now, for the next one, I'm going to have you lie on your stomach for me, okay? Let's say for whatever reason you had a patient that just had a lot of trouble turning over and it was a real chore for them and you happened to find them on their stomach and you didn't want to disturb them. Well, what's to stop me from doing my hip rotations in the prone position? Nothing. It's a little different angle, but it'll still work. You bring them up like so. I'm going to pull the leg this way, okay, as I internally rotate the femur. Here's my barrier. I tap it right here. She pulls opposite to that, and she holds that with about 20% of effort for 8 to 10 seconds. 8, 7, 6, 5, 4, 3, 2, 1, and release and take a nice deep breath for me. And I would just go ahead and repeat that 3 or 4 times. Remember, the breath is very important. It allows the muscle spindles to reset much easier, and it's good because people don't breathe enough, in my opinion. Okay, and again, if we're doing the other rotators, we'll just go this way. These are the internal rotators. I bring her over that way. She's got a lot of motion there, but there's the barrier. I tap her on the inside of the ankle. She now moves her ankle toward me, just the opposite of the position I pushed her in, for 8, 7, 6, 5, 4, 3, 2, 1. Release, take a nice deep breath, and repeat that 4 or 5 times. And make sure you do the other side. Now, as long as I've got her here, the rectus femoris is a muscle which spans 2 joints. It crosses the knee, it crosses the hip. So this is a muscle which gets tight on people. And one of the best ways to correct that is with muscle energy. And all you do is you bring them up like so, and you're trying to bring the heel down toward the buttock, and I hit that first little bit of tension. Now, on her case, I'm actually feeling movement right here. I'm actually feeling her pelvis start to rock a little bit. That's a barrier. You got it. Even before I feel the tension in the front. So what I do is I take her a little bit beyond, I just kind of tap her right here, and she pushes into my hand with about 20% of effort for 8 to 10 seconds. There's 8, 7, 6, 5, 4, 3, 2, 1. Release, tap her, nice deep breath. Good, and then I go and I start to stretch. And my whole idea here is to go so slow in stretching that they barely feel it, just like I'm doing. And look at all the motion I'm picking up here. And then I start to get that little bit of motion. You can see my hand rock a little bit. So I've hit that barrier. I go a little bit further, but look at how far I am now. Ask her to push again against my hand. She pushes on this hand right here. Good, for 8, 7, 6, 5, 4, 3, 2, and 1. And release, and nice deep breath. Good. And now I'm going to go ahead and even push further and further and further and further, and go ahead and stretch and repeat that 4 or 5 times. If the patient has a tight hip flexor, and that test would have been done prior to the treatment, but you would test them for a tight hip flexor, and if you found that one hip flexor was tighter than the other, or they were both kind of tight, as we see in our modern society, one of the nice muscle energy techniques, and I'm going to show you 2 for using muscle energy on the iliopsoas complex, is as such. I'm going to have you slide as close to me as you can get. And I do this for body mechanics, so I don't hurt myself. You want to do this for years and years and years to come, but if your body mechanics are poor, you're going to hurt yourself and you're not going to be able to do it. What I'll do is I'll come down here and I'll put my hand right under there and kind of cradle the foot up against my upper arm. My hand is here to monitor anywhere on the back of the pelvis. You'll feel it. And what you do is you bring the leg up in the air when I get that first hint of motion in the pelvis. Now I'm going to give you a little clue. I'm not side bending. I'm actually pushing off of this foot to tip me up in the air so I don't have to hurt my back. So you just want to lift up a little bit. You've got adjustable tables, lift up a little bit. Oh, there's my barrier right there. I go a little bit beyond it. I tap her underneath the leg and I say, pull your leg down to the table with about 20% of effort. So this is, go ahead, you can pull it down to the table. So this is not straightening the knee. I don't want them to straighten the knee. I want them actually to pull the front of their leg down to the table. And some people will instantly try to do that. That's not what I want. I want them to pull it down to the table. So I'm going to tap her and she's going to pull down to the table. She's going to give me about 20% of effort for about 8 to 10 seconds. So 8, 7, 6, 5, 4, 3, 2, 1. Release. Nice deep breath. Good. And then I'm just going to do my gentle stretch, 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 stretch. Wow, look at all this I just picked up on her. All of that is new motion. And finally right there I get to the tension barrier. I tap her again and I have her pulled down to the table. And she holds it for 8, 7, 6, 5, 4, 3, 2, 1. Release. Nice deep breath. Good. And then I stretch and stretch and stretch and stretch. Good. The last technique that you can use for a tight hip flexor, and although it's a little bit more involved, is really the best technique. I really like it, and it really doesn't use as much energy as you would think. There's a lot of strength in lifting that leg off of the table, but I'm going to show you a way to do this one when the patient is face up, supine, that really is a little bit easier and gets a little bit better results. And the patient will actually help you because you're going to tell them what to do. But what I'm going to do is I'm just going to show you something real fast. I'm going to actually want this leg to come down this way, but instead of using my muscles and get tendinitis, I'm just going to hold her right up against the side of my body, just like that. So my muscles, my adductors are actually doing the work here. And I don't have to use my wrist and I don't have to use my hands very hard. And you'll know when you get a heavy person, the last thing you want to do is do a lot of bull work, okay? So I'm actually going to, instead of raising her leg like this, I'm going to slide it right down the side of my body. I'm using almost no muscle effort to do this, and this saves you, the therapist, a lot of use and abuse on your shoulders, your elbows, your wrist. Now what we've got to do here is a couple things. I've got to control this side of the body. I got to control this leg, because if she's using her pelvic muscles to control this hip, she's not going to relax the iliopsoas muscle. So I got to figure out a way to do that. It's easy for me because I got this real long arm. I can sneak under here and actually hold her in place, and she can relax her muscles with that foot up against my chest. She's completely relaxed. I'm holding the leg. But you may not have arms the length of mine. So what I'm going to do is I'm going to ask the patient to simply do this. You're responsible for that leg now. Okay? I'm going to reach over. You can spread your entire hand over the front of the pelvis. You don't even have to find a landmark here. You're going to pick up psoas or iliacus, because whichever one is tightest, it's going to jump into your hand first. And you slowly slide that leg down, just slide it down, and when you feel the first hint up, there's our first hint, I'm going to go a little bit farther, and now all I'm going to say is, take about 20% of the weight of that leg off of my hand. Good. I don't even have to use any resistance. She's using the resistance of her own leg. 8, 7, 6, 5, 4, 3, 2, 1. Relax, nice deep breath. There you go. 2-3 seconds there, resets the muscle spindle, and I just let that leg slide to the next barrier. Oh, there's the next barrier. I can feel her back lifting a little bit. I can feel a little tension in the muscles. It takes a while, but you'll get it. And you go a little bit further, and then you tap her and you say, okay, good, just lift about 20%. That's it. That's all you need. And my resistance, if there is any, is it holding her leg against the side of my leg. Very simple. 5, 4, 3, 2, 1. Release. Attaway. Nice deep breath. Good. And then you just slowly lower that down. You need to do that 4 or 5 times. Okay? Now what's important, don't walk away from the patient. You're leaving them very vulnerable here. And I realize to do this technique, you've got to get up close. You've got very close to them. Doing it this way hurts you, the therapist. Explain what you're doing, move in this tight, and there's no stress on my body whatsoever. When the technique is over, you say to the patient, let me lift the leg, and then you just kind of slide it up a little bit, you get it up here, and then to get out of it, what I do is I brace myself and have the patient just push on my chest with her feet and inch herself back up the table. Go ahead. She just inches herself that way. And until her legs can touch the table comfortably, I don't walk away. And now her legs are on the table, and then I can walk away from that technique. When we think about the pelvis, it's important to think about this part of the body as a force transducer. It takes the forces that we create when we walk and somehow turns them into usable energy so we can propel ourselves. It also has to balance out the forces from the upper body, and it does so by use of this very interesting little intermediary bone called the sacrum. The best way I like to describe it for people doing muscle energy is that you've got a door frame and a door. So you have to fix the frame first before you fix the door. And if the door frame is not squared away and the door is not squared away, what's above the door, the lumbar spine, is not going to be nice and symmetrical as well. So I like to start here, and I know there's some controversy about that, but I like to start here at the muscles of the hips and the pelvis and get this all balanced and doing really well before I move on to the sacrum and before I move on to the lumbar spine. So your joints that we're really going to be concerned about are the iliosacral joints, the joints between the ilium sacrum, and also the pubic bone. Those are the real joints that we concern ourselves with. The pubic bone is the keystone of the arch of the pelvis. If you ignore it, if you're too uncomfortable to go and palpate the pubic bone, you have pretty much doomed your patient not to get well. You have to correct it if it's dysfunctional. So there's a real reason why I insist that you do, and it's basically because of pelvic biomechanics. Now, a little bit about rotation of the ilium. When you take a forward step, which will look like this on the side, you expect rotation of the ilium. If I step forward, I expect this ilium to rotate posteriorly as the draw of the hamstrings pulls on the ischial tuberosity. As I then finish the step and I'm in this position, the iliacus muscle pulls that ilium into an anterior rotation. It's supposed to happen. That's absolutely normal gait biomechanics, and we look for that when we watch somebody walk. When these things don't occur as well, we'll see what I call a hitch in the get-along. You'll see somebody who just doesn't seem to be walking smoothly. Another thing occurs, and that is a flare. So along with rotation of the ilia like this, you'll also see flaring of the pelvis in and out. When I take a step like this, the leg that's hanging back is actually pulled inward. The pelvis is drawn inward just a little bit for an in-flare, while this one over here is pulled into just a little bit of an out-flare. Then when I reverse the steps, they go this way. It's a tiny little bit of motion, but it's normal to occur, and when it doesn't occur, it creates problems, either right on the spot or down the road as the body adapts to it. So those are your physiologic motions. And I call them physiologic because they happen in a day-to-day basis. And nobody worries about them. They're there, they're supposed to be there, and there's nothing really harmful about them. Now, there's two motions which occur and create a lot of havoc, and I'm going to call those pathological. And those are a pelvic upslip, a pelvic downslip, an elevated pubic bone, an inferior pubic bone. Let's talk about pubic bone first, because remember I said the pubic bone is just so vitally important for going ahead and making sure the pelvis is corrected. Well, sometimes a pubic bone gets stuck up in the air, and that's called an elevated pubic bone. Sometimes the pubic bone gets stuck forward, and that's, again, we still call it an elevated pubic bone. Sometimes a pubic bone gets stuck down, and that's called an inferior pubic bone. And sometimes it actually gets stuck backwards. It's actually in deep. Again, we call that an inferior or depressed pubic bone as well. So you've got these pubic bone lesions that are going to have to be fixed, and these are what we call pathological. They create a lot of problems. In fact, they probably hold some of the other problems that are going on as well. There's also something called an upslip and a downslip. Let's say you were taking a step off of a curb. The only thing is you didn't know it was a curb there, and you're just walking like normal, and all of a sudden, whoa, you come down way too hard, and the force through your leg actually drives your ilia way up in the air. That's an upslip. What happens is the quadratus lumborum instantly says, oh, there it is, and it grabs it, and it catches it, and it holds it there until somebody comes along and fixes it with your muscle energy technique. All right, the same thing can happen on the other side. If you land really hard on one leg, the other leg, if it's free, it'll drop down like that. Or if somebody tugs on your leg, I had a trapeze artist one time who got caught with one leg on the trapeze and somebody grabbed him and it just pulled him into a downslip. That can happen, you know. You'll see it more than you think. But the pelvis does not only just rotate and flare, but the pubic bone goes up and down, and the ilia can even shift up and shift down. And those are going to be the things that we're going to cover when we do our work here in muscle energy on the pelvis. Now let me talk a little bit about structural and functional leg length. I've had people say to me over the years, well, everybody has a little bit of difference in their leg length. And I'll say to them, you know, I'll agree with you until after I treat them. Once I treat them, I make that correction. We were not born to have different leg lengths. Every once in a while, and I mean it's very rare, you'll actually get somebody with what's called a structural leg length difference, where either the tibia or the fibula is actually longer or shorter. And that's structural, and you're not going to do a lot for that. But chances are, if they've been walking around on a structural leg length discrepancy, the pelvis had to adapt as best it could, and they may have pain regardless. So you still want to go up there and correct what's going on in the pelvis and the sacrum and the lumbar spine, because you can get rid of their pain. You may not change a whole lot of the leg length, but some of that leg length problem may be as a result of the pelvis moving around. Because after all, when your ilia rotates posteriorly, your femur behaves short because the acetabulum moves up. Now, if your pelvis just gets stuck rotated anteriorly, that's going to take the acetabulum, that's going to take the socket, and it moves it down a little bit. So what's attached in there is your hip bone, and that makes your leg behave longer. So that's called a functional leg length difference, and it's being caused by an abnormality in the pelvis. Those are 100% correctable. Even up to 2 inches in leg length difference, you can correct a leg length difference with muscle energy if it is functional and not structural. But just because someone really does have a true leg length difference that is structural doesn't mean you shouldn't go to treat them, because chances are you will improve upon that as well. And it's all due to rotation. So let's try a couple scenarios here. If I've got an ilia that is anteriorly rotated, we expect that the leg will behave long. If it's posteriorly rotated, what do you got? We expect it to be short. If the pubic bone on one side is up higher, we expect that that leg will probably behave a little short. If the pubic bone is depressed on that one side, we think that leg is probably going to behave long. That makes sense. What about an upslip? I think this is pretty obvious. When the pelvis is upslipped, that leg's going to behave short. When the pelvis is downslipped, that leg's going to behave long. And that's the very basic mechanics you need to understand what we're going to do when we make these corrections in the pelvis. There are 4 standard tests for checking the mobility of the IS joint, the iliosacral joint. A lot of people say SI, but that's what we're going to be covering later, sacrum having problem on the ilium. This is a problem of the ilium acting on the sacrum. Okay, so there's 4 standard tests. They're called the standing forward bend test, the stork test, and then 2 more that are done lying down called the squish test and the tug test. So what we do is we just kind of find the iliac crest, and usually if you just let your thumbs rest, you come fairly close to the posterior superior iliac spine. If you're looking for it, it's where the dimples are. Most people have dimples, and that's a great place to find it. What you want to do is come under the dimple and push up against the shelf of the posterior superior iliac spine. And that's because when the patient does bend over, you want to see which side is moving. So if I got my thumbs right underneath the PSIS, and I'm looking for symmetry, and she looks pretty symmetrical, and that's good, but let's see if she's hypomobile. I'm going to have her bend over as far as she can, and I just follow my thumbs, and look what happened to my left thumb, and then come on back up. My left thumb actually moved up. That is a positive sign for SI dysfunction on the left. Let's say you've got a patient who's a little thick in the tissue and you're having trouble finding the PSIS. No problem. All you do is have the patient just sit right down. When they sit, it moves the tissue out of the way. And all I do is come back down there and I can really feel those bones. Okay? Now this is where some people make a mistake because they have the patient bend over here. That's another test altogether. I'm going to have her stand back up. All right, now I've got the posterior superior iliac spines, and if I was concerned about it I'm on there right now. I have her go ahead and bend forward. She bends again, and again I see that left side just come way up in the air and come on back up, and that is a positive test for the iliosacral dysfunction on the left side. What if the opposite hamstring, her right hamstring, was so tight that it held this side back? This side would appear to be positive because it moved, when the problem is the hamstring is tight on the opposite side. That's the reason we like to clear those long restrictors of the hip and pelvis first. So that really helps out so that you know by the time you get here, you're dealing with some good length and good tension relationships that are going on in the muscles of the hip. There's another test called the Stork test, and that test is a little bit different because the patient's going to actually pull their knee into their chest. What I'm going to do is get on the PSIS again, and she's got easy ones to find, and I'm going to have her pull her left knee up into her chest. And she grabs it with her hands and she pulls it right up, and I see a certain amount of motion. Okay, good, down you go. Then I have her repeat it on the other side. See how much further the other side moved? The right side moved an awful lot further. Down you go. What that tells me is this side didn't move, and it was supposed to move. The left side was the one I was expecting to move. It didn't move as much as the right. So now I've got two positive signs, two positive indicators that I've got a hypomobility at this IS joint, at this articulation. Okay? And it gets a little confusing because on the forward bend, it's the side that moves the most. That's your positive, your red flag. On the Stork test, the knee to chest, it's the side that moves the least. That tells you where your positive indication is going to be. We have a couple of techniques that you can use if the patient can't stand, or maybe you got some conflicting information from the first two tests, and it will happen. For the squish test, it's probably the most difficult, or one of the most difficult tests, because it requires a certain amount of upper body strength. So I put my hypothenar eminence basically right on that anterior superior iliac spine and just let my hand rest on the iliac crest. Then I put the other one over on the same side and do the exact same thing. Now, I can't do the test from here because if I push down, I'm going straight into the table. That's not the way the joint lines up. The joint goes this way. So what I've got to do is I've got to angle myself over the patient so that basically my nose is right over the center of her body. And then what I do is I flare my elbows out like that. So now if you look at my arms, they're coming in at a 45-degree angle. If you don't do this, you will not get a good test. So I come over here and I push gently with one side and I assess how much spring I get. I push with the other side and assess how much spring I get. Now I'll just tell you right now, this side doesn't spring as well. And if you're okay with that feeling of what springs and what doesn't spring, you can stop right there and say, there's my hypomobile IS. Another way to think of it is this. If I push on her left side and it gives and gives and gives, and all of a sudden the force comes over to this side and I feel this hand move, I say, that force must have stopped and transferred to this side. And I say, all right, now let's compare it with the other side. I get in that position again and I push over here and it gives 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 and it gives, and finally I feel it on this side. It took longer for that force to lock up and be transferred. So there's another way of saying this is your hypomobile side. And just to stress, you can't do it from here. You've got to get down and you got to get your nose right over the midline so you can use the power in your chest and your arms to put this test on the patient. Okay? Now, the last test, I'm going to have her lie on her stomach. Her SI joints are right in here. And to show you the beauty of this test, you really don't have to be super accurate. If you're anywhere in the vicinity, you will feel this. I'm going to have you abduct the leg maybe 15 to 20 degrees, and that's all you need. Now, I squat down a little so that I'm in this line because I'm going to use my muscles in my arm, and I'm going to do a long axis tug and a long axis compression. And I just tug and I compress and I tug and I compress, but really what I'm doing is feeling how much motion I feel at my palpating hand. I say, okay, I have something to base it on. Let's do the other side. Abduct it a little bit, come out, change my hand over to the opposite side, long axis tug, long axis compression, and I feel how much motion this side. And I think you can see that this side just gives a whole lot more than this side. There's just way too much binding on here. So now we're going to take a look at the actual symmetry, and we want to find what is symmetrical and asymmetrical by looking at the bony landmarks. So the first two landmarks are the anterior superior iliac spine. The other landmarks we're going to use are the superior pubic bone and the anterior pubic bone. We're also going to show you how to palpate the iliac crests, the ischial tuberosities, people call the sit bones. The last thing that we're going to show you how to palpate when we're working on our pelvic dysfunction is the ankles. I'll have my patient lie down and bend her knees up for me, and I've already determined the hypomobile side earlier, and it was her left side. I'm going to have her raise her hips up in the air, and the reason I do this, and down you go, is so that her pelvis doesn't get skewed on the table. Sometimes tables have a crack in them, and some of the big treatment tables have a real big separation. I want to get her, her behind up above that so that I don't have any problem with the hips being off because of the table. I come down here. I gently say, on 3, let me have your feet, 1, 2, 3, and I just draw them out like that, and I don't tug on them. I just draw them out, and I'll shake them a little bit if I want, just to get some tone out of there, and then I'll look with my dominant eye, and I'm assessing which of my thumbs is closer to her head and which of my thumbs is closer to me. And as it so happens that my thumb, which is bumped up against the inferior portion of the medial malleolus, is closer to her head. It's up. So I've got a short leg on this side. I come up to the pelvis. I like to move the pants out of the way if I can, but if I can't, I pull them up as high as I can so that I've got a nice solid background to look at. Sometimes a person has a belt that's off a little bit like this. That's why I like to get the clothes out of the way. If at all possible, pull down a little bit. I come underneath the anterior superior iliac spine and I push up. And I take a look at my thumbs and say, which of these thumbs is up or down? And in this case, what I find out is this thumb on the left-hand side, which was her hypomobile side, is actually closer to her head by about 1/4 of an inch. And it only needs to be about 1/4 of an inch. This side is closer to her foot, but I'm not going to worry about this because it's not the hypomobile side. All right, people always make that mistake. So I'm looking at this. Here we go. She's got this is elevated here, so we're going to call that a posterior rotation. She's got a short leg and a posterior rotation, and my mind is already going, oh, that's in pattern. I don't have a problem with that. So after we've done the anterior superior iliac spines and I'm looking for ilial rotations, I keep my thumbs right where I had them. And what I do is I just swing my fingers up and see if my fingers are asymmetrical on a midline of her body. Now, most people, the midline of the body is the belly button. Every once in a while, you've had somebody who's had surgery who has some myofascial restrictions, and the belly button is way over here. You've got to just picture chin in between the chest, right down the middle of the belly, right through the pubic bone. That's your midline. And you put your thumbs right here, you swing over like that, and you say, are these fingers actually symmetrical on her midline? She does not have a flare. Now I want to palpate the pubic bone. You want to come from above down, never below up. You put the heel of your hand kind of just in the center of her tummy and you come down until you bump the pubic bone and you slide your thumbs. As I slide my thumbs down, I notice that my thumb here on the right hand, on her right hand side is down, but I don't care about it because it is not the side that's having a problem. The thumb on the left-hand side is a little bit closer to her head. So that is an elevated pubic bone, and I roll it up on front, and it is actually a little closer to the ceiling, so that counts, either or both of those counts as an elevated pubic bone. Okay? So I've got a short leg, posterior rotation, those are in pattern, but I also have an elevated pubic bone, and guess what? That's in pattern too. There's nothing here that's out of whack, okay? Everything is as expected. No paradoxes so far. Then what we want to do is flip the patient over on their stomach, okay? And I always bring the patient down a little bit so that their feet hang just off of the table, okay? Now, there's a reason for this. If she's on the table and the table is hitting her here on her foot and she's got some tight anterior tibialis or she's got some tenderness or some sunburn, the table's going to irritate her, and so she'll instinctively tighten her hamstring. When she does, I won't be able to get into the ischial tuberosity. So I get her or put a pad under there or something so that she's nice and relaxed and she doesn't show any tension in there. And then what I'm going to do is come in and I'm going to find the gluteal fold. Everybody's got a gluteal fold. Some are bigger than others. You actually go into that fold at a 45-degree angle, like this. Okay? You go down on the one side, you go down on the other side, and you push in until you feel something solid. Then I push toward her head. Once I'm on something real solid, I know I've found the resting positions of the ischial tuberosity, and I'll tell you in a minute what we're going to do with that information. We're trying to assess, is one of them up or down? Is one of them down or up? We need to determine, but again, since we've already determined that the left side is hypo, that's where I'm going to put all of my attention this first round. So I come in there like this, I push down at a 45-degree angle, up at a 45, or just up toward her head. What I've got is a deep thumb on the left. This thumb is upwards, and the thumb on the right is not, it's downward, okay? So, does a deep thumb go with a short leg? Yeah, it does. Okay? We call this an upslip. The whole side of the pelvis somehow, some way got jammed up, stepping off a curb, whatever. There are pathological lesions, and by pathological I mean they're more serious. And then there's called physiological lesions. They're physiological. They occur in a routine and regular day as we walk, as we move, as we stand. But pathological lesions are lesions that occur that are not supposed to occur, and they get stuck there. And they carry a lot more weight when it comes to muscle energy, and they carry a lot more weight when it comes to dysfunction in the body. My pathological lesions are asymmetries of the pubic bone, either on the superior surface or on the anterior surface, and or problems at the ischial tuberosity. When you find asymmetry here, these are the ones that your radar should go right to and say, I got to pay attention to these guys because these are probably causing the other problems. And I'll tell you how to find out which one to treat. Your physiologic lesions are your inflares and outflares. And here's what an inflare would look like. If I say that this left side is inflared, this anterior superior iliac spine is actually rolled in and closer to the belly button. And I'll show you how to look for these in just a minute. If I had an outflare, this anterior superior iliac spine is actually rolled out and further away from the belly button, once again on the hypomobile side. Ignore the side that is fairly normal as far as mobility. Makes things a lot easier. So now we know that your pubes and your tubes, ischial tuberosities, are your pathological problems, and they should always be addressed first. And your flares, and now the rotations, because when this ilia rotates this way, the whole side of the pelvis rotates. This guy comes up north. It moves up a little bit. And an anterior rotation would look like this. So a posterior rotation, an anterior rotation, an out flare, an in flare. An elevated pubic bone on the left or a depressed pubic bone on the left. It was down here. Okay? This would be called, if this bone was deep, it would be called an upslip because the whole side of the pelvis slid up. If this bone was prominent, it would be a downslip. All right? And it just takes time to learn and get used to the palpation. So we've got 4 things with the pelvis that we're going to address. Elevated depressed pubic bones, upslips, downslips, flares, and rotations. Now there's something very specific about that order, and this is where the treatment sequence comes in. The treatment sequence tells us where to treat first, because if we're smart and we pick the primary lesion, the other things just disappear. And it's the most amazing thing. You'll go back and say, hey, wait a minute, it was there a minute ago and I didn't treat it and it's gone now. I must have made a mistake. No, chances are you did not make a mistake. Chances are you got the primary lesion and you should be congratulated for that, okay? So here's what we say. Pubes, tubes, flares, and rotations. And I'll be reminding you of that. Pubes, tubes, flares, and rotations. When the pubic bone is elevated or depressed, that's a big thing. When you've got an upslip or a downslip, as measured at the ischial tuberosities, that's a big thing. When you've got a flare or a rotation, those are not as big of a thing. They're not going to cause you as much dysfunction. They may cause you some dysfunction. And if you certainly had an isolated one, you just want to fix the isolated one. But your treatment sequence in almost every case goes pubes, tubes, flares, and rotation. And if you wanted to stop and turn your brain off right now, don't lose that treatment sequence. Treat your pubic bone problems first, treat your upslips, downslips, your tube problems, and then your flares and your rotations. If I have a paradox, I have to treat the paradox first. Now, what's a paradox? There are certain components of the dysfunction that we expect certain things, and most of you know this. If I have an anteriorly rotated ilium, I expect that the acetabular socket is going to be south a little bit. It's going to be down. That's going to make that leg appear longer. I expect it. If I have a posteriorly rotated ilium, I expect the acetabulum to move up a little bit and that leg will appear short. It's structurally not short, it's what we call functionally short. What if you don't get it? What if that's not what you find? In other words, I have an anterior rotation, which you'd think would be a long leg, but suddenly that leg is short. That's a paradox. If you find that because of an elevated pubic bone, you expect the whole side of that pelvis to rock backward a little bit as the pubic bone comes up, we expect that. We would expect the leg to be what? We would expect it to be short. But what if it's long on the hypomobile side? What if it's long? You say, well, how could that be? How could you ever experience that? And what if you had an ischial tuberosity that had slid down and it was very prominent on the hypomobile side, and you expect the leg to be what? Long, but you find that the leg is short. Those are paradoxes, and you have to treat them first. Ignore, and I'm going to say it again, ignore your physiologic paradoxes. Don't worry about the flares and the rotations when it comes to paradoxes. If you got a posteriorly rotated ilium and a long leg, those don't go together. Ignore them. They are going to get corrected when you fix the rest of the things. The only reason and the only way you vary from pubes, tubes, flares, and rotations is if you have a paradoxical ischial tuberosity. That is the only time you will deviate from pubes, tubes, flares, and rotations is with that ischial tuberosity that is in paradox. Either an up ischial tuberosity with a long leg or a down ischial tuberosity with a short leg, and that's it. Pubes, tubes, flares, and rotation unless the ischial tuberosity is in paradox. And then you treat the paradox first. So in the wild case that you have a double paradox, you say, well, first, Tom, how could you possibly have an elevated pubic bone, an upslip, and have a long leg? That's impossible. Not so. You have to remember that in the living body, the pelvis is malleable. It's not a rock-solid bone like a plastic or a dry desiccated skeleton. These things can be molded, and they're molded by the force of the muscles depending on how long the muscle is doing its bad thing and how strong the muscle is pulling. So if it's been pulling for quite some time, it will actually slightly change the shape of the pelvis, which will change where the acetabulum is, which will give you a different leg length. So the only reason we're really looking for leg lengths, well, two reasons, is to determine what? Paradoxes. And because when we correct the pelvis, it's always nice to go back down and see that the person has equal leg lengths as well. All right, now we're ready to actually do the treatments for the pelvis. There are 8 actual treatments for doing your pelvic dysfunction corrections. And remember, you're going to be working on your hypomobile side. I cannot stress that enough. So her left side is hypomobile. I'm going to have her slide towards me, and I'm going to stand on her left side. I want her as close as I can get her. In fact, I'd like half of her buttocks off of the table, but I'll stay right here so she feels supported. Their hand instinctively goes to the table. That's good. This is important. I have to grab the leg in a certain way, so I'm going to bring the leg up like this. I have to reach my arm on the inside of her leg and grab her just above her ankle, okay? If I don't, I can't do all of the motions for this. All right? So now what I'm going to do is, I've got this perfect. I got to get my thumb on the pubic bone, either the anterior or the superior spot, it doesn't matter. I'm going to look for my barrier. And I bring that leg off of the table and I drop it down. Oh, and there's my barrier. And then I back off ever so slightly. Remember, this is different from doing muscle energy. We back off of the barrier with articular muscle energy. I now just rotate back in my foot and I bring her into abduction. So I took her into extension of the hip first, barrier, back off. Abduction of the hip, barrier, back off. The last thing I do is I rotate externally by bringing her foot and ankle up toward the table. Each of these has to be done without being disturbing the previous barrier. So I get my extension barrier back off, don't disturb it. I got to get my abduction barrier back off, don't disturb it. And now I've got to get my rotation, external rotation barrier, don't disturb it. And you back off ever so slightly, and then I ask the patient to pull the left knee toward the right knee with a pound of muscle contraction. So she's just a pound. Most people will pull way too much. A pound is a very, very simple little bit. And that's 8 seconds, 7, 6, 5, 4, 3, 2, 1. Release, take a nice deep breath. I'm supporting her leg. She's doing nothing. But when I ask her for a contraction, she gives it to me. I now go to the next barrier. Up, there's a new barrier, back off. Oh, now the abduction barrier, back off. Now the rotation barrier, back off. And remember, I'm calling that barrier by feeling movement at the pubic bone. She pulls against my elbow, just a pound of pressure, pulling it toward her other knee. She pulls her left knee toward her right. Holds that for 8 to 10 seconds. 8, 7, 6, 5, 4, 3, 2, 1. Release, take a nice deep breath, and let that leg go. Good. And then I do 2 or 3 more, and I bring her back up on the table, scoot her in the middle, and then I would go ahead and check my symmetry to see if I did what I was supposed to do. That's for the elevated pubic bone on the hypomobile side. Now, if we're going to treat the depressed pubic bone, it's very simple. I leave the patient in the middle of the table, I bend the knee, and I get the area in between my thumb and my index finger right on the tibial spine or right on the patellar ligament, either or. Anywhere here is good, and you just kind of give it a grip. My other hand goes, again, right on the pubic bone. I bring her up, and these are the exact opposite motions of the ones I just did. I just did extension, abduction, external rotation. Now guess what? I'm going to do flexion, a deduction, internal rotation. I will say push against my hand right here with about a pound of pressure. And she holds it for 8, 7, 6, 5, 4, 3, 2, 1. Release, take a nice deep breath. Good. And then I go for my next barrier and I say, okay, let's go up a little bit here. Up, there's the barrier, good, I found it, back off. Up, go to a deduction. Oh, there's my barrier, back off. A little bit more rotation, there's my barrier, back off, and I hold it right here and I say push with 1, there you go, just like that. For 8, 7, 6, 5, 4, 3, 2, and 1. And relax and take that nice deep breath. I do a total of 4 or 5 on that, and I go back and assess my symmetry. Did I get them corrected the way I wanted to? A little tip, if you've got a large leg and you're a small person, one of the ways that you can do rotation, if I don't have a lot of strength in my hand and I got a big person here, doing that is going to be very tough. All I got to do is come over and grab it this way and pull them that way. And now they're pushing into my shoulder as they do that push into extension. Okay? Just a little something in case you're mismatched with the patient. There's always ways to do this. Now we're going to treat an upslip. The old way to treat the upslip involved a little bit of a manipulation, and I didn't like it, and if the person had a bad knee or a total hip, it could put that in danger. So I came up with a way to correct the upslip which involves absolutely no manipulation whatsoever. And it's very simple. You come down and you grab the ankle and you abduct the leg maybe 15 to 20 degrees and you bring it up in the air into flexion of the hip just about the same amount. The last thing I need to do is internally rotate. This is important because if you don't internally rotate, the force that I'm going to put here to correct the upslip is going to go to the hip socket and not the SI joint and the IS joint. So I've really got to make sure I've got this position right. So a little bit of flexion, 15 to 20 degrees, a little bit of abduction, 15 to 20 degrees, as much internal rotation as I can get until I get a nice comfortable stop. And then watch, all I do is lean back. As I lean back and take a little pressure off of the SI, I ask the patient to take deep breaths. As she breathes in, her pelvis wants to move toward her head. As she breathes out, I feel it coming to me, and I encourage it. As she breathes in again, the pelvis wants to move toward her head. I don't let it. As she breathes out, it comes to me, and I encourage it to do so. I do that 3 or 4 times. When she breathes in, the pelvis wants to move toward her head. I don't let it go. As she breathes out, as she exhales, it comes to me, and I encourage it to do so. And at the very bottom of a breath, she's going to finish this cycle. At the very bottom of the breath, I'm going to say cough twice. As she does that, that SI joint just finishes right down into position. Go into the gluteal fold, go down 45 degrees, push up until I hit something solid, and see that my thumbs are absolutely right next to one another. Now I'm going to show you how to correct a downslip. The easiest way to correct a downslip is again to use the patient's breath cycle, just like I did with the upslip. It requires no manipulation whatsoever. I come along, I abduct the leg maybe 15, 20 degrees, and that just loosens the SI, the IS joint just like before. I take my hypothenar eminence pisiform complex right here, the heel of my hand, and I have to lie this right into the gluteal fold. So I come into the gluteal fold and I get in just like that. And this is critical. If I'm not on the ischial tuberosity, if I'm up here, she will never relax. So I've got to be right on that bone so that if I took all of my balance points away, I wouldn't go anywhere, right on the ischial tuberosity. And then what I do is I say, okay, I want you to take some very slow, deep breaths in. And as she breathes in, that ischial tuberosity wants to come to me. I don't let it. As she blows out, as she exhales, I push up a little bit. As she breathes in, it tries to come to me. And I say, nope, you're not going anywhere. As she exhales, the bone moves toward her head. As she breathes in again, the bone tries to come to me and rocks a little bit. As she exhales, it goes to her head. And then I say, just at the beginning of a breath, cough twice. As she does that, that bone just finishes off in the right position. And I would at that point bring the leg back in, go into the gluteal fold, go down 45 degrees, push up until I hit something solid, and see that my thumbs are absolutely right next to one another. So those were the pathological dysfunctions. We want to always treat those first. Now we're going to go on to the physiologic dysfunctions. And in sequence, pubes, tubes, flares, and rotations, the flare is the next thing that we're going to treat. So if she has an inflare on the left, then this left anterior superior iliac spine is actually a little closer to midline. I want to pull that out. So I'm going to bring this up, and this is very simple. I'm going to have her just move her hand for a second. I'm going to get on the anterior superior iliac spine and let her rest her knee right up on my stomach. As I let that leg slide down on my stomach, just like that, I said, oh, there's my barrier. I feel the tension. I tap her right here and say, pull this way with about a pound, just a pound. And she holds it just like that for 8, 7, 6, 5, 4, 3, 2, 1. Release, take a nice deep breath. Good. Now I go to my new barriers. And see, the only barrier here I'm doing is just flopping that leg out to the side. It's just external rotation, really, and a little bit of abduction. There's my new barrier. I back off, tap her, pull with a pound of pressure. 8, 7, 6, 5, 4, 3, 2, 1. Release, take a nice deep breath. Good. And I do that 3 or 4 or 5 times until I think I've got it all done. And I bring it up and I do my test and I see if I've actually got her lined up the way I wanted to line her up. You've probably figured it out already, but the treatment for the out flare is the exact opposite. All I do is same position, put my thumb there, and all I'm doing is pushing this way, pushing into the center of the body. I feel on the anterior superior iliac spine, and if some people have a big enough hand, they can actually go down and get the posterior superior, that's fine with me. You want to feel that pelvis rock in. Oh, there it is. You back off and say, push towards me. So she pushes her knee towards me, literally with no more than a pound. As she does that, 8, 7, 6, 5, 4, 3, 2, 1, release, take a deep breath. Good. And then I say, let's go to my new barrier, and I push this way. Oh, I feel the pelvis move. I back off a little bit. She pushes towards me again. 1 pound of muscle contraction. A lot of patients want to give you more than a pound. They really don't have to when your articular work is being done. And release and take a nice deep breath. And I'll do that 4 or 5 times, and then I'll go back and I will check and see if I did in fact correct my out flare. The last thing we're going to treat are rotations. And if we have an anterior rotation of the ilium, the anterior superior iliac spine will actually be down. It'll actually be rotated down. It'll actually be closer to her foot on the hypomobile side. This is very simple to treat. And you've actually seen this treatment technique before because it is virtually identical to the treatment for the depressed pubic bone. With the exception, you don't palpate the pubic bone, you palpate the anterior superior spine. So up we go, and instead of being down here for the pubic bone, I am now up here at the anterior superior iliac spine. I'm going to do it identically. I get down here on the tibial spine or the patellar ligament, either or. I bring that leg up until I feel the ilia begin to rock, and I say, oh, there's my barrier, back off. Good. I go into the middle. Oh, there's my barrier, back off. And then I internally rotate. Oh, there's my barrier, back off. And I have the person push with 1 pound of pressure on my hand. So they're pushing to the end of the bed. And 8, 7, 6, 5, 4, 3, 2, 1. Release, take a deep breath. Good, we'll do that one more time. I bring it into a little bit more flexion. There we go. There's my barrier, back off. A little bit more adduction, there's my barrier, back off, and a little bit more internal rotation, there's my barrier, back off. Just push on my hand. There you go, good. For 8, 7, 6, 5, 4, 3, 2, 1. Release, nice deep breath. I'll do that 4 or 5 times. I'll bring that leg back down, and I'll check and see if I corrected that inferior anterior superior iliac spine, the anterior rotation of it, okay? So, the last one we're going to treat, and again you'll recognize this right away, is if I had a posterior rotation. So I slide her over to the edge of the bed. She's going to get a half of her buttock off of the table for me. Good. I stand right here so she doesn't worry about going anywhere else. I don't want her to be nervous, because if she's tightened up and nervous, I'm not going to get this done. Her hand instinctively goes there. That's great. And if you remember from before, from treating the pubic bone, I reach inside and grab the leg just above the malleolus, so my forearm rests on the inside of her leg. I bring her off the table, so my finger palpating the anterior superior iliac spine. I drop her into extension. There's my barrier, back off. Abduction, there's my barrier, back off. And now I externally rotate the femur by lifting her foot toward the table. And there's my barrier, I back off, and I ask her to pull with 1 pound, pull her left knee toward her right knee, and we hold that for 8, 7, 6, 5, 4, 3, 2, 1. Release, deep breath. Good. And now I'm going to go down, I'm going to up, there's my new barrier and extension, I back off. There's my new barrier and abduction, I back off. There's my new barrier and external rotation, I back off. Ask her to pull her left knee toward her right knee, and she pulls with 1 pound. 8, 7, 6, 5, 4, 3, 2, 1. Release, take a nice deep breath. Good. And I'll repeat that 4 or 5 times. Bring her back up, scoot her into the middle of the table, and go ahead and check and see if I did my work. When a joint has been hypomobile, it forgets what job it's supposed to be really doing, and it's in a place that's a little strange to it. So the muscles and the muscle spindles that were causing this thing to be a less than optimal position may actually need a reminder to stay in place. So I always teach some very gentle stabilization. Every once in a while you get one that no matter what you do doesn't stay in, and then we have to go with belting and things of that nature. But I've got 2 or 3 nice exercises that you can use to get the person stable, and they really only need to do them for about 2 weeks, but they're going to do about 30 reps every day. But they have to do it for 2 weeks because it's going to take about 2 weeks for those muscles to go, oh, okay, this is where they want me, this is where they want the bones to be, I'll be good, I'll stay here. So that's an important thing. And the exercises are quite simple, and anybody can do them, virtually anybody can do them. And there is also a concept which makes this easier to remember, and that is if your house is not sitting on a level foundation, so here's your foundation of your house and the windows and doors are perfectly framed at 90 degrees, that's great. But if your foundation starts to sag a little bit, suddenly those windows are not framed at 90 degrees. They're actually framed off a little bit. That's what happens when you get a leg length problem, all right? So they're actually walking around on an unlevel sacral base. So now you've corrected that with all of your nice muscle energy work on the pelvis, and you want to pack a little dirt around the foundation before you drive away. You want to make sure that that pelvis stays in place. So one of the things that we teach the people to do, and it's right after I treat them, boom, after I fix the pelvis, even before I go on to the sacrum, I say, let's do your stabilization exercises, and they go like this. They're very simple. Have the patient bend their knees up like this. They can either push their hands or their elbows into the mat. It doesn't matter, but they're going to push down like that and raise their hips at the same time and go as high as you can and hold it for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and down. And that's just perfect. Some people go 1, 2, 3, 4, 5, 6, 7, 8. No, no, no. 1, 1,000, 2, 1,000. You want to hold it long. And they're up there and they hold it for 10 seconds. They do that 30 times a day, but not 30 times at once. You want them to do 5 or 10? Go away, do something else. Come back later in the day, do 5 or 10. Go away, do something else, okay? So that's what we want to have them do. And it's important they do that because they're using their glutes and their lats. The left hand latissimus and the right hand glute, and the right latissimus and the left-hand glute cross at the dorsal lumbar fascia. When they contract, that stabilizes. So as she pushes her arms down, she's engaging her lats. As she raises her behind up in the air, she's using her glutes, and that helps to hold the correction that you just did such a nice job of putting in place. Another great exercise for stabilization that's very easy to do is gently contracting the adductors and the abductors. And if you think about it, you can do it anytime you're standing. But what I do is I come down and I just put my hands between the knees and just say squeeze with about 10 pounds. Most people will want to crush your hands. Don't. You'll pull your correction out of place. Just 10 pounds of squeeze for 10 seconds. 5, 4, 3, 2, 1. Now press apart for 10 seconds. Good. 8, 7, 6, 5, 4, 3, 2, 1. And she only does it with about 10 pounds of contraction. She'll do 30 a day, but not 30 at once. She just gently squeezes and uses the adductors and then uses the abductors. And those then pair up with the lats and the glutes and really help to hold that correction in place. The last exercise technique I like to give for patients to stabilize their pelvis, and it's doubly important for females, especially if they're over the age of 40 and especially if they've had children or have had any type of abdominal surgery, is something called roll for control. I didn't invent it, but it's a lovely technique that actually lifts the pelvic floor up in the air and will have some greater improvements and consequences later on down the road in terms of not having incontinence issues and things of that nature. And it's very, very simple to do. All you need is a stretchy band and a squishy ball. Just all it has to do is squish. You don't want anything firm. You place the band around the knees. So patient bends their knees up a little bit. You put it in like this. Good. And although the patient bends the knees to don this apparatus, they don't keep it that way. Now the ball goes right in between and the band kind of holds it there. The knees squeeze together and she comes out flat. Good. Now here's what she's going to do. She's going to roll, not spread. She's going to use the external rotators of the hip. The external rotators of the hip, the obturator internus is one of them. It attaches to the pelvic floor. It actually raises the pelvic floor up in the air, and in so doing helps to stabilize that correction that I made. She holds it for 10 seconds. 5, 4, 3, 2, 1. Then she rolls in, and again, she's not squeezing, she's rolling inward, and she holds that for 10 seconds. So 8, 7, 6, 5, 4, 3, 2, 1. And then this is important. She rests right in the middle for 10 seconds. The reason is this muscle, if it is underdeveloped, will cause a lot of pain and a lot of lactic acid to build up if you just think you're going to power through this and do 30 of them at once. That whole sequence of out for 10 seconds, in for 10 seconds, and resting for 10 seconds should be done 30 times a day, but definitely not 30 times at once. You want to do it flat out. You don't want to have your legs partially bent. You get your best stabilization with it flat out, and it's just an easy thing to add to their protocol. You can use a little piece of TheraTube. They could use anything from a roll of toilet paper to some bubble wrap if they didn't want to go buy a ball, but the ball needs to be squishy, okay? And I just have them do 30 a day of those, and that goes in conjunction with the other exercises. So for the next 2 weeks, they are to do their hip raises, they're to do their squeezes and presses, they're to do the roll for control protocol, they are to avoid intercourse positions in the missionary position, but they can use other positions as long as they're weight bearing, and then they avoid any stretching that involves one leg at a time. If they want to stretch both hamstrings at the same time, that's fine. Great, as long as both legs are moving in the same direction at the same time, they're fine. I encourage them not to jog or do any type of jumping. Snowmobiling, riding wave runners and jet skis, any of that stuff that's going to hit them hard, but elliptical trainers are good, bikes are good as long as they're not jumping the curve. You just want to keep the earthquakes out of the pelvis. We're almost done. The last thing that you may need to do when correcting a pelvis, after assessing the side that is hypomobile, assessing what the asymmetry is, treating the asymmetries, stabilizing the asymmetries, is if this occurs. Let's say you line the patient up beautifully and they're symmetrical and everything looks great, but when you do your testing for hypomobility, you find out they're still hypomobile. In that case, you may need to do something called the ligament recoil, and I'll show you those. And the ligaments that we're going to recoil are the sacrotuberous ligament, the sacrospinous ligament, and then the iliolumbar. These ligaments sometimes tighten up if they've been hypomobile for years. And you'll know this because the patient said, yeah, something feels better, something feels different, but I still feel like it's not right. You go back, you test them, boy, they're symmetrical, everything looks good, and then you go and do your hypomobility test that we did before, and you find out they're still hypomobile slightly or majorly on the one side. That's when you use these ligament recoils. What you want to do is you want to have one hand. I like to take my thenar eminence and put it right up on the sacral ILA, and the sacral ILA is just basically to the side of the coccyx, okay? Sacral ILA. I take my other hand, I turn it around so that my hypothenar eminence is now resting solidly on the ischial tuberosity. And what you do is you press down and you take up some slack, and you have the patient take nice deep breaths, and if she takes a breath in, I try not to let anything move here, and as she exhales, I stretch. Okay, she takes a breath, I try not to let anything move, I hold her, I hold her, I hold her. As she exhales, I stretch. And once again, she takes a nice deep breath, I hold it as best I can. As she exhales, I stretch, and then just as she starts her breath again, I get off of it that fast. I really want you off of it that fast. It does you no good to do that. That won't do a thing. You've got to just let your hands fly like that so that the ligament actually recoils. So that's the treatment for sacrotuberous. Let's go to sacrospinous. People say, geez, I haven't thought about these ligaments in years. Well, all you do is you keep the same hand position and you slide it out about 45 degrees. So here you're at a 45-degree angle going from the ischial tuberosity up to the sacral inferior lateral angle. Now you're just going to move about 45 degrees to the outside, and you do the same thing. Now the spine of the pelvis is way deep in here, and it's just to the back of the acetabulum. So all you need to do is move your hands like that, and you are there. This hand, thenar eminence right up against the border of the sacrum. This hand, hypothenar eminence right out to the side laterally. Deep breath in, exhale. Good, and I go down with her. And as she comes up and breathes again, I try not to let it move. And as she exhales, and I go down even farther. Good, and as she takes her breath to come in, there you go, good, and she blows it all out, 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 out. And just as she's coming back again, I get off of it that fast. Okay, last one is iliolumbar, and I get one side of my hand, one hypothenar eminence right here along the iliac crest, okay? And the other hand slides underneath it, hypothenar, right up under here. And now what I'm gonna do is I'm gonna push this way. The problem is with this one, you really don't have a lot to grab on, so if you're on clothing, you might skip. So you really need to go in there and get your hand on the back of the iliac crest. This hand actually goes in and contacts the transverse process of L5. So what I'm going to do is come in here, and you get really close. Your hands are actually touching like this, okay? You slide under, move that hand over so it's contacting L5. She takes her deep breath in, and she exhales. We stretch. She takes her big breath in, and I don't let it come back. Do my best job I can. As she exhales, I go down with it. Good, 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 good. She comes up again, and she blows it all the way out. And just as she starts to come up again, I let go of it. Okay, just like that. And that gets that ligament to start doing it. Now I do that 3 times at every point. 3 point at sacrotuberous, 3 times at sacrospinous, 3 times at iliolumbar. And then if you want, you go ahead and do all your tests, your tug test, your squish test, your standing forward bend, your stork test, to make sure that you finally have restored symmetry and mobility to that side, and you are done with the pelvis. When we think about the sacrum, they're somewhat triangular in shape. And back in the Greek mythological times, anything that was shaped like a triangle was considered mystic somehow and somewhat sacred. So they called it the sacred bone, and as it adapted in its language, they just started calling it the sacrum. It is a very irregular bone. There's only one of them in the body, and it has more bumps and cracks and grooves and crevices on it than you can shake a stick at. The only thing we really need to concern ourselves with when we're actually palpating the sacrum is a couple of very simple landmarks. The inferior lateral angles, the ILAs, right here and right there, and it's not the coccyx, it's kind of above and out to the side. And if you notice, they come in on a bit of an oblique axis. That's what we want to put our thumbs on when we're palpating, okay? The other 2 landmarks you're concerned with are the PSIS, because you need the PSIS, posterior superior iliac spines, in order to find what's called the sacral sulcus. So you put your fingers on the PSIS, you move in a centimeter and up a centimeter, and you go deep, and you get to what's called the sacral sulcus, and you'll do that on both sides. And based on the position of these 4 landmarks, you will be able to call whether you're dealing with a sacral torsion or a flexion extension dysfunction. On my little cardboard here, what I've done is drawn base, apex, inferior lateral angle, and I've got these oblique axes running through it. The oblique axis that starts in the right corner is called the right oblique axis. The oblique axis that starts in the left corner is called the left oblique axis. And these are what we are now going to use to understand a little bit more about sacral biomechanics. For instance, the sacrum has the opportunity, as I said, because it doesn't just spin on a long axis very much, it has the opportunity to rock forward and rock backward on one axis. It also has the opportunity to rock forward and rock backward on the other axis. Okay, fine. Sometimes when it rocks forward, it gets stuck. Sometimes when it rocks backwards, it gets stuck. Just like it could here. It could rock forward here, and it could rock backward there. What we have to do first is determine which of these is stuck, okay? And then how do we go ahead and treat them? That's our goal for the sacrum. So let's review just a little bit. The sacrum is named, and the sacral position is named via osteopathy based on how the front of the sacrum is facing. For instance, since that's the left side of the room to you on the camera, when the sacrum is going this way, it's facing left. When the sacrum is going this way, it's facing right. Okay? So here's the possibilities for sacral torsions. And remember, a torsion is a side bending and rotation to the same side as opposed to a pure vertical spin. All right? When the sacrum moves this way, it is facing which way? Hopefully you're saying left. All right? Which is the oblique axis that the sacrum has rotated left on? It's the left oblique axis. All right? But if the sacrum rotates backwards, it's facing which direction? It's facing the right, but it's still on the left oblique axis. When the sacrum rotates forward, it's facing the right and it's on the right oblique axis. But if it rotates backwards this way, it is now facing the left, but it's still on the right oblique axis. You've just learned the axes of rotation for the sacrum. That's for torsions. Flexion and extension are a little different. Flexion and extension require me to use the foamy sacrum. You will actually find, as I said, when the sacrum flexes, nutates, it goes this way or this way, and then when it extends, it goes this way. It doesn't just spin in the middle. But what if you find a sacrum that looks like this? And you say, and I'm exaggerating this, but what if you find it looks like this? Well, you got a problem, and this is called a unilateral flexion dysfunction. And this is called a unilateral extension dysfunction on this side of the, right there, the left side. So what we're going to do is show you a method to palpate and then figure out which one of these dysfunctions you have. And then, just like before, we're going to go ahead and show you how to treat it. When we palpate for sacral problems, after we've cleared the hips, after we've done the pelvis, we're going to come in and we're going to look for the sacral ILAs and we're looking for the sacral sulcus. All right? And let's say we find that in palpating, you push down here and you come in really deep into the sacral sulcus. And at the same time, you also find a prominent and or posterior ILA on one side. That tells you something, because if it is deep on the right, the sacrum has got to be facing the left. And that gives you a clue to the first letter in that little formula. This is a left-facing sacrum. We know which way it's facing, and we know that it's a torsion because I've got red flags on both sides. I got the prominent ILA, inferior ILA on one side, we got the deep sulcus on the opposite side, so we know it must be a torsion. If I say, all right, I'm a torsion and I'm facing the left side, how do I determine if it's really stuck forward on the right or stuck back on the left? It could be one of two things. I'll actually have the patient come up on her elbows, and she comes up on her elbows and rests her chin in her hands. Good. Now, when the sacrum, when the lumbar spine goes into extension like this, the sacrum's job is to move forward. If, when she did that, this inequity right here evened out like that, and these sulcuses even out, I know that this side, the left side, did what it was supposed to do. It moved forward. So that side's not stuck. This side is stuck, and it was stuck forward. Okay? So now we have a left-facing sacrum on a left oblique axis, and it is stuck forward. And that's how I would deduce what's going on. So let's look at that with the patient laying down, and I'll get the sacrum out of the way. I'm just palpating. I come along and I palpate that I have a prominent and or inferior ILA on the sacrum right here. I come up and I find the PSIS. We found these earlier. And I go in a centimeter and up a centimeter, and I dig in. And I really don't dig, that's the bad term. I sink in, and I go very lightly until I get resistance. Okay? So if I sink in, and as you can see here, the right is deep. So I've got a deep flag, deep sulcus right here, red flag. I got a red flag on this side. I know I'm dealing with what? It's got to be a torsion. Okay? Have to be torsions because the red flags are on opposite side. But is this facing the left and stuck forward on the right, or is facing the left and stuck back on the left? I have no idea. I have to introduce motion. And when the lumbar spine goes into extension, come up into extension for me and just rest your chin on your, there your hands, right on your hands, good. And I follow this down and the left side actually goes down and catches up. So the left side's doing what it's supposed to do. That's not my dysfunctional side. The right side is my dysfunctional side. And therefore, that is a left on left forward torsion. All right, good, let's do another one. I'm going to place my sacrum up here. And let's say I come across the sacrum and I find that I've got an ILA that is prominent and inferior on the left and the sulcus which is deep on the right. And I say, okay, no problem, I've got a torsion. I'm okay with that. But is it stuck forward on the right or is it stuck back on the left? Well, if I have her, and you see it's facing the left, so we're okay with that. It's a left-facing sacrum, but we don't know if it's stuck back on the left or forward on the right. Here's what we do. I have her go ahead and come up on her elbows or rest her chin in her hands, and it gets even worse. This one goes even deeper. Now, it won't go this deep, but it goes even deeper. So this side, what? Did what it was supposed to do. It's not stuck. The problem is this side, and it's stuck backwards. So this is a left-facing sacrum on a right oblique axis. So that's how you determine your axes, okay? You can't just look at the position. You have to introduce motion. You have to do a motion test to figure out what's going on. All right, wonderful. Now, what about flexion extension dysfunction? So we covered a backward torsion and a forward torsion. What about flexion extension dysfunction? If my red flags, which are deep sulcuses and prominent ILAs, are on the opposite sides, we know it's a torsion. But what if they're on the same side? What if I'm palpating in here and I find that she's got a deep sulcus on the right, but she's also prominent on the right as well? I say, whoa, well, we know it's not a torsion, so it must be a flexion extension dysfunction. If it is a flexion extension dysfunction, is it stuck forward on the right or back on the left? I don't know yet. What am I going to have to do? I'm going to have to introduce motion. So I have the patient come up on her elbows, and as she comes up on the elbows, this one moves down as it's supposed to, so this one's free to move. So my hypomobility side is this side. So this is called a unilaterally sacral flexed sacrum because it was deep to begin with, unilaterally flexed. All right, let's try it again. She's flat. I come in here and I find that I've got a deep sulcus here, prominent ILA on this side. We're on the right side now. And I say, okay, well, I know it's not a torsion. I know this is a unilateral sacral flexion extension dysfunction, but what do I got? Do I got a flexion dysfunction on the right or do I have an extension dysfunction on the left? If I have her come up on her elbows and rest her chin in her hands, and this goes even deeper, then I know this one moved as it was supposed to. This was the problem side over here on the left, and this is a sacral extension dysfunction on the left, unilateral sacral extension on the left. Let's take it one more step. I'm going to have you flatten out for me. What if in these flexion extension dysfunctions you find they're extremely deep sulcuses on both sides, all right? And you find that they're quite prominent in the back. And people like this will not like to forward bend because the sacrum cannot move back. It's supposed to move back when they forward bend. When we have her come up on her elbows and press, these go really, really deep and they do so symmetrically, then you've got a bilateral sacral flexion dysfunction and you treat each of these differently. What if you find a sacrum that is very, very shallow in the sacral sulci and then very, very, very deep down here in the ILAs? Well, then you've got this situation where you go, geez, I can't even find the sulci because they almost don't exist. What you've got is a sacrum that is stuck back in this position. And when you go to have her come up on her elbows and rest her chin in her hands, what'll happen, she goes, I can't, it hurts. And what's going on is the sacrum is stuck backwards. It can't come down, and it's stuck backwards bilaterally. This is a bilateral sacral extension dysfunction. It should have dropped in. It didn't. One of the nice things I like to do as I'm about to treat a sacrum is just to put my hand on top of it and listen to it wiggle. And the sacrum actually moves around and dances a little bit. And what I can do is kind of show you what it does. As I put my hand on the sacrum, sometimes the sacrum is attempting to flex and extend as it's supposed to, but sometimes it can't because it's hung up somewhere. So it tries to flex and has to roll to one side, or it tries to extend and has to roll the other side. And sometimes if you're really good, you can pick up on this. And it's a nice way to go back and check your work. You just set your hand here, kind of close your eyes, and just feel the sacrum as it twists and moves. And again, if it goes into flexion, which is nutation, or counter nutation, which is extension, if you do that, it should move just real nice like that. And that means the sacrum is kind of a happy sacrum. It's really doing what it's supposed to do. If you find that it kind of rocks around like this, on a very small scale compared to this, but if you find it rocks around a little bit, sometimes the sacrum just likes it when you put your hand down there and kind of steady it a little bit. And then you can go back and check and see how it feels after you treat it. Now, the first thing we're going to do is treat a unilaterally flexed sacrum on the left. And just to remind you what that looks like, you find a situation like this, and when the patient comes up on her elbows and rests her chin in her hands, the other side actually catches up to it. All right, so we know that it's stuck forward here. And here's how you treat that. Go ahead and flatten out for me, please. You have to come down to the sacral ILA. And remember, we talked that the sacrum really doesn't flex about an axis like this. It actually moves this way and it moves this way. So what we want to do is kind of give some props to that and respect it and try to go through that motion as the sacrum is returning back to its normal position. So what I do is I take my hypothenar eminence, I find the sacral ILA, I get right over it just like this, and if I need to reinforce it, that's okay. As the patient takes a breath in, the sacrum will go into extension, and I follow the ILA down to the table. As she breathes out, it tries to come back. I don't let it. As the patient takes the breath in, I follow it down to the table. As she breathes out, I don't let it. As she takes a breath in, I follow it down to the table. As she breathes out, I don't let it. I do that 4 or 5 nice slow breaths, and then I change my force. I come down here, and now instead of pushing down to the table like I did at first, I'm going to push up toward her head. So as she takes a breath in, it wants to come to me. I said, no, you don't. I hold it there. As she breathes out, I coax that sacrum toward her head. As she takes her breath in, it wants to come to me. I say, no, you don't. As she blows out, I coax it toward her head. We do that 4 or 5 times, and then I go back and check my symmetry and see if I corrected it. All right, just like that. Good, and one more, and I follow it up. And again, that is paying respect to the fact that the sacrum has to do this and this to get back where it went, or how it got stuck. All right. The opposite is true for a sacrum that's stuck as an extension. So we got a sacrum stuck in extension on the left, and we would find this, a deep sulcus on this side, and when she comes up on her elbows and rests her chin in her hands, that sacrum actually goes even deeper. So we know automatically this guy's stuck back. It's stuck in extension unilaterally on the left. Our positioning for this is to have her lie flat. And now I've got to get my pisiform hypothenar eminence right in the sacral sulcus, so I actually get on her tissue. If I'm on her skin, I will slide. It's just not going to work, so I got to get on the tissue. Pick that up, slide that in there, and I want to get in the sulcus. And remember, the sulcus, you find the PSIS, you move in 1 centimeter, up 1 centimeter, and there I am right there, and I slide my pisiform hypothenar eminence right there, and I come down here and I push toward her foot. And as she takes a breath in, I move that sacrum down to her foot because it wants to go. And as she exhales, I don't let it come back. As she takes her breath, I push that sacrum down. As she exhales, I don't let it come back. I'll do this 4 or 5 times, just going with the sacrum, encouraging it to go where I wanted it to go. Just like that. Good. And then when I'm finished with that, what I do is I move up and sit right next to her on the bed. So I took care of the part where the sacrum needs to move down. Now I got to get the sacrum to move down to the table. So we were inferiorly pushing. Now we're pushing toward the anterior surface of the body. As she takes a breath in, the sacrum should go down to the table. I encourage it to do so. As she blows out, I go right with it. As she takes her breath in, I don't let it come back out. As she exhales, I go down with it. As she breathes in again, I hold it right there. As she exhales, just like that, I keep going down with it, and I do this a couple times. Exhale, down with it I go, down with it I go 4 or 5 times, and then I stop, and I come back, and I check my work. And that's how I would treat a unilateral extension dysfunction. But what if, as we talked about a little bit before, you have a bilateral sacral extension or a bilateral flexion? It's the same treatment, but the position that changes is your hand. For instance, if she is bilaterally extended, I need to push her down here, but I need to put my hypothenar eminence and my pisiform right here as opposed to over in the sacral sulcus. If she's bilaterally flexed, I need to go with my hypothenar eminence pisiform and I need to go in between both ILAs and push down this way and go back up this way. So this is what it would look like. She's bilaterally flexed. She's got very, very deep sulcuses. Nothing much happens when she comes up on her elbows. And I say, wow, that's a bilaterally flexed sacrum. What I come down here is I find the coccyx and I move to the ILA and say, all right, that's good. And I go right in between them. And now, as she takes her breath in, I push down to the table. You can see me exaggerating. As she exhales, I try not to let it move. As she inhales, push it down to the table. Try not to let it move. As she inhales, I go down to the table. As she exhales, I try not to let it move. And I'll do that. And then I'll come down here and still right on that same spot. Now I'm pushing toward her head. So she takes her breath in. It tries to come to me. I don't let it. As she exhales, I encourage it to go toward her head. As she takes a breath in, I don't let it move. As she exhales, I try to get it to go close to her head. And again, my force is in the center as opposed to the ILAs on the side. Conversely, for a bilaterally extended sacrum, I'm going to get right in between the sacral sulcuses. So here's my sacral sulcus. I go in a centimeter, up a centimeter. I go right there and I slide my hand right like that. And I push as she takes a deep breath in. I push toward her feet. And as she exhales, I don't let it come back. And as she takes that deep breath in, I follow it toward her feet. I help it along. As she exhales, I try to prevent it from coming back. I do that 4 or 5 times, and then I very gently come up and sit next to her, and I follow the sacrum down. And as she takes a breath in again, I try not to let it move. As she breathes out, I follow the sacrum down, try not to let it come up. As she breathes in, follow the sacrum down, and I do that 4 or 5 times, and go back and then just check and see, did I in fact restore my symmetry? All right, now we're going to show you how to actually treat the torsions. In this case, we're going to use as an example a right-on-right forward sacral torsion. And a right-on-right forward sacral torsion really means that it is stuck forward on the left. And it never hurts to see the review again, but what I find is when she's lying there, I find a deep sulcus on the left and a prominent and/or inferior ILA on the right. So I know we got a torsion. We know that the sacrum is facing the right. And when I have her come up on her elbows and rest her chin in her hands, this side drops down. Okay, so it did what it was supposed to do. All right, we have to pull this guy back. We're gonna have to pull this guy back. So what happened is as she comes up, this guy got stuck this way. And I know we're good because this side moved in, so that's not the bad side. This is the side, and it is stuck forward. So now what we got to do is I got to pull that backwards. And for this, I'm going to have her lie on her side. And I always want you to remember another little cheat rule. Always put the side that is stuck toward the ceiling. You'll never get lost. Just that's a little cheat rule. Put the side stuck toward the ceiling and you'll be fine. All right, so here I am. I've got my finger right in the sacral sulcus. I'm going to come down and grab the feet, and I'm going to put both of her knees right here in the crease of my groin, and I'm going to pick her up a little bit, and I'm going to bring her up, and oh, there's my flexion barrier, because I felt the sacrum start to move back. That's good. I want it to move back, okay? Then I sneak under the sheet, and I slide up here, and I get the back of her shoulder. Sometimes you can grab the pillow, and I slide her forward a little. Oh, there's my barrier, and I back off. Then what I do is I push this arm just down to the table a little bit with my elbow, and I push, oh, and there she's rotating forward. Now what she's doing is she's rotating right. If she rotates her trunk to the right, the sacrum rotates to the left. And so now I'm just in a perfect position to throw in the side bending. So as I drop her legs off at the table, I am now side bending her to the right, which means the sacrum will rotate to the left. And I come down here and I feel my barrier, and I say, push your feet to the ceiling with about a pound of pressure. So she tries to raise her feet to the ceiling with just one teeny little pound. That's all I need. And 8, 7, 6, 5, 4, 3, 2, 1. Release. Take a nice deep breath. Good. I hold her still. I pick her up and I move her up again. There's my new barrier. Oh, back off. Good. I switch up here. I reach under the pillow or under the sheet, grab the back of her shoulder, bring her forward a little bit. Oh, there's my new barrier. And again, that's down here. I rotate her down this way. Oh, there's the barrier, back off a little bit. Drop the legs off the table again. There's my side bend. Oh, push your feet to the ceiling, 1 pound of pressure. Just like that. I've got her rotated and side bent to the right, and that's going to cause the sacrum to move back to the left, which is exactly where I want it. Good. Release, deep breath, and I will do that sequence 4 or 5 times, and I'll go and check my work. Now, I'm going to leave her right here for a minute because I want to tell you something. If you're a small therapist working with a big patient, or you've got very small arms, there's something that you want to do that'll make this very easy. You still go and get your barriers. Here's a barrier, here. You get the barrier from above down, you get the rotational barrier, we're all set up. But picking up these legs and dropping them could be a lot of work. So what you do is this, you take your forearm right around the hip joint, and while you're palpating, you push down to side bender. I side bend her right there, and I got that gapping, and I back off, and I say, now don't let me push you. I'm going to put a little pressure, and she just gives me 1 pound of, just 1 pound of muscle contraction. She actually is contracting quadratus lumborum. And when she does that, 8, 7, 6, 5, 4, 3, 2, 1, release, take a nice deep breath. Good. And then what I'll do is I'll go take my barriers from below up, from above down, my rotational barrier, I'll get right on the side of that hip again, push it down, wait till I feel the barrier here, and oh, there's my barrier, good. And I say, now don't let me push you, and I'm pushing down on the hip, I'm pushing here, and she just fights me, she fires the quadratus lumborum. And this works beautifully if you're a small therapist working with a big patient. All right? And then what I would do when I'm all done is I put her on her stomach and go look and make sure that we made our corrections. Now we're going to do a right on left posterior sacral torsion. All right? And I'll just review how I came up with that. Okay? I found that there was a deep sacral sulcus on the left and a prominent ILA, prominent and/or inferior ILA on the right. So I know automatically we have a torsion. The sacrum, if it's deep on the left, is actually facing right. So there's the right side of that. When I have her come up, and she comes up on her elbows, okay, this one actually goes even deeper, so I know that this one is stuck back. And hence, what has happened is it did this, it right on left. It faced the right side, and it did it on a left oblique axis. The other way of saying is it's stuck backwards on the right, okay? Very good. So now what I got to do is I got to get this thing to go forward. I got to get that to go into the table. And I'm going to use the position of the lumbar spine just like I've been doing, because the lumbar spine, again, moves opposite to the sacrum. So here's how this is going to look. And remember, you always put the stuck side toward the ceiling. So this time, I'm going to have her lie with the stuck side toward the ceiling, okay? And this arm now doesn't stay behind you. It stays in front of you. Good. Okay. So I'm going to put that arm like this. Here is the sacral sulcus, all right? It is stuck back, and I need to move it forward. I'm going to take the top leg and move it out of the way. Good. I'm going to take the bottom leg, and while I'm palpating for my barrier, I just slide it backwards, and oh, there's my barrier, and I get a chance to back off. I then slide under the sheet or under the pillow, contact her shoulder, and I slide her back just nicely like that, till I hit my barrier and I back off. And what you can do is if you put your elbow on the front of your hip, you can just use your body weight as opposed to trying to pick the person and manhandle them. So that goes nicely. Then what I'm going to do is put this hand right through here, and I come over and I connect my 2 fingers right to the sacral sulcus that I'm trying to move. All right? So I'm trying to get this guy to go in. So I've taken up my barriers from below up. I've taken up my barriers from above down. Now what I want to do is take up my rotational barrier. I rotate her to the right, and that makes the sacrum rotate to the left. Okay, so the sacrum's doing this, I get to my barrier, I back off. The last thing I want to do is sneak under here. I'm going to actually sit right on the treatment table, and I'm going to pick the heel toward the ceiling. When I do, I engage my right side bending barrier. I tap her underneath the heel and say, pull that to the floor with just a pound. And guess which muscle she's using? Piriformis. And the piriformis pulls the sacrum forward. So it really assists me at making this correction. Release, take a nice deep breath. I put this leg down. I reposition from here. I reposition from here. I reposition here. And I get back on the table, scoot under like that, put her in her side bending barrier, And there I go, and I get the barrier there, and I have her pull down again right to the floor. 1 pound is all that's necessary, and you can actually feel the sacrum move forward when you do this. It's really fun. Just like that. And release and take a nice deep breath. I'll do that 4 or 5 times, and then I'll go ahead and check my work. One last thing, we only did 2 torsions. We did the forward torsion and the backward torsion. But remember that you may find a forward torsion that is facing the opposite way from what we just did, or a backwards torsion which is facing the opposite way. All you do then is put the stuck side toward the ceiling. So rather than repeat the technique again, which would be identical with the patient facing the other way, we're just telling you that, remember, you may have to treat in a slightly different position, but it'll be identical, just a mirror image of what you did. You may start to doubt yourself, because you may have seen a right on right sacral torsion and treated it, and now you've got a left on right, or a right on left, or a unilateral sacral extension dysfunction. And you think, oh man, I must have done something wrong, and I didn't see what I thought I saw. Chances are no. Chances are you did it correctly. You've merely found the second layer of the sacral dysfunction. As you know, we humans don't stop dead in our tracks just because we get a little ache or a pain. We keep moving, we keep walking, and the body is very good at adapting, and part of its adaptation is to actually take that sacrum and put it in a place where we can walk as best we can, even though it's not perfect. But after a while, the body says, I can't stand that anymore, and it starts to come up with a new way for you to walk, and the sacrum has to layer itself. So you may have to go through a couple of layers. The take home here is, finish the sacrum till there's no more dysfunctions. You might have to do 1 or 2, you'll get good at it and you'll feel comfortable with them, but you may see a totally different picture after you fix it the first time. Go ahead and treat it just the way you found it. What you need to understand is the spine is a collection of hockey pucks with jelly donuts in between. And it allows the spine to extend, and it allows the spine to flex. And that's wonderful. But if these little joints in the side that are called facet joints, sometimes these little joints get hung up. They can't move the way you'd like them to move. So if you bend forward and one side moves but the other one doesn't, you're actually going to get a rotation in the spine. If you go backwards and one side moves but the other one doesn't, you're going to get a rotation. Those are the things that we're going to look for when we actually go ahead and start treating the lumbar spine. But what I want to do now is put another layer of understanding onto that and do some arthrokinematics. My elbows are the transverse processes of the spine. So here is one spinal segment, okay? If I bend forward and everything is moving beautifully, both of those transverse processes are going to move very symmetrically, and it'll look perfect. If I bend backwards, just like that, and the facets are working perfectly, then both of those transverse processes will move perfectly and you will see no asymmetry. But remember, we've said we're looking for hypomobility and asymmetry. Here's an asymmetry. Let's say I bend backwards and I end up seeing this. Now I'll exaggerate, but my right transverse process becomes very prominent. And you say, I wonder what's going on there. Well, if you think about the arthrokinematics, what happened is this facet could not go into extension. As it comes backwards, this one becomes prominent, and we find that this one is stuck forward. You see that? If we came back and this happened, it would have moved beautifully. If we come back and this happens, the right facet moves beautifully, the left facet is stuck. Let's try another one. I bend forward. If everything moves perfectly, great. But what happens if I bend forward and this happens, where I get a prominent left transverse process? Which one moved the way it was supposed to? The right side, because it came up and forward. Which one didn't move? The left side, and there's your stuck facet. So when we're evaluating a patient to find out if the lumbar spine is flexed or extended, all we need to do is put a little flexion or a little extension on the lumbar spine, and we can find out which of those is asymmetrical and hypomobile. And it's just really that simple. Let's try another couple of examples here. Let's say I've got the patient lying on their stomach, and I have them come up on their elbows, and I see this. And I'm going to ask you a question. Which one of those transverse processes did what it was supposed to do? Your answer should be the left. It came backwards. Which one did not do what it was supposed to do? The right, because it got stuck forward. If it had done what it was supposed to do, it would have come back and they would have been symmetrical. But what do we call this? Well, with osteopathy, we always name the part of the spine from looking at the back of it and which way it's facing on the front. So in this case, we bring the patient backwards and we see this, we find that the segment is rotated to the left, okay? And it's stuck open on the right. So what this is actually called is a forward flexed or a flexed, side bent and rotated lumbar spine if we just had one segment. So if we put the letters down, it would be FRSL, flexed, rotated, and side bent to the left. That's fine, and you can put that down on your paper, an FRSL. The fun thing with the lumbar spine is you treat it with just the exact opposite movement. So if I've got an FRSL, I'm going to treat it with an ERSR. I'm going to extend it, side bend, and rotate it to the right, and that's how I'm actually going to treat it. Let's try another one. If I flex forward and I end up with this scenario with a very prominent transverse process on the right and a not so prominent transverse process on the left, I can say who did what they were supposed to do. Well, the left side moved the way it was supposed to. The right side got hung back for some reason. And what hung it back was a tiny little muscle in the spine called the rotatory. All right? So in this case, our problem is this one. This one is stuck where? It's stuck in extension, because if it could flex, it would move fine like this, but it's stuck in extension. So the first letter in what we're going to call it is an E, and I'm side bent to the right and rotated to the right. So this is an ERSR, extended, rotated, and side bent to the right. To treat it, what are we going to do? We flex it, we side bend it, and we rotate it to the left. Those are called type 2 single segment dysfunctions. And the type 2 single segment dysfunctions are defined by being one segment and one segment only. And they are caused by a traumatic event or one muscle that just goes a little haywire, gets too much tone in it, and holds that in a less than optimal position. But there is something other than type 2s. There is something called type 1s. And type 1s are a scoliotic curve. So rather than just having one segment that's misbehaving, you could have a whole bunch of segments that are misbehaving. And those segments are called type 1 dysfunction. So what does a type 1 look like? A type 1 looks like a bunch of the transverse processes will all be prominent. So let's say here on the right side, you look at the spine and you just find 2 or more that are all rotated to one side. And I'll show you how to palpate that in a little bit. You'd say, wow, I got two of these levels here that are all rotated one way. Guess what? You've got a type 1 dysfunction. The type 1 dysfunction is characteristic of rotation one way and side, so it's rotated here to the right, but it's also going to be side bent to the left. And that's what we need to know when we figure out what we're going to do to treat them. Basically what we have found here is we have a patient with an ERSR, extended, rotated, and side bent to the right. We need to fix her by doing just the exact opposite. I've got to flex her, side bend, and rotate her to the left. So how am I going to do that? Well, first, let's look at how we came up with that conclusion. If I'm palpating the lumbar spine, and remember, we always palpate ever so slightly. We don't dig into the tissue. We basically just set our thumbs down. As we set our thumbs down, I find that the right facet is actually prominent. Her transverse process is actually a little bit higher toward the ceiling. I'll exaggerate it for you. And I say, is this stuck closed on the right or open on the left? It could be either or. I don't know yet, okay? But what I do know is it is rotated to the right. The problem is it stuck flexed on the left side or extended on the right side? Well, as you know, I have to introduce motion. I have to do a motion test on her. So I'm going to have her come up on her elbows and rest her chin in her hands, and all of a sudden it equaled out. Now let me explain this to you. If it equaled out, it means that the left transverse process came back. It was allowed to come back. It wasn't tied up. By default, the right one is my bad boy, and that's the one that I'm going to have to fix. My cheat rule that I mentioned was, if you find it and you call it as ERSR, to fix it, you're going to FRSL. That's exactly what I do. The other cheat rule is she's going to actually put the stuck side toward the ceiling. So let's go, let's have you lie on your side, stuck side toward the ceiling. There you go. This arm's got to go behind her for treating an ERS. Dysfunction, because I actually have to turn her face to the table. So what I'm going to do is I'm going to take her legs and I'm going to bring her up until I feel flexion, and then I back off. Switch hands, kind of sneak in under, grab her shoulder and bring her forward, and oh, there's flexion, and then I put her down. I roll her chest to the left side, oh, there we go, and back off. And then the last thing I do is drop her legs off of the table. And when I hit my barrier of side bending, I ask her to push her feet to the ceiling with only 1 pound. That's perfect. You can barely feel it. That's all you need. You hold it for 10, so that's 8, 7, 6, 5, 4, 3, 2, 1. Release. Nice deep breath. Let me hold everything. Deep breath. Good. And then what do? I bring her into a little bit more flexion from below. Set the legs back up, hold them in place, sneak under, lift your head for a second, thank you. Slide her over this way. Oh, there's my new barrier. Good. I gently push her down toward the oh, perfect. Back her off just a little bit. And sometimes you can actually prop the arm up in there to hold it. And I come back here and I take the feet and I drop them to the floor. And now I've got all barriers and I back off and I say, push your feet to the ceiling with just 1 silly little pound. That's all you need. 8, 7, 6, 5, 4, 3, 2, 1. Release, take a deep breath. And I would do that 4 or 5 times and go back and check my work. Okay, and you can relax for a second. One point I want to make is, if she's too close to the table, to the edge of the table, she won't relax. I got to make sure that she is well on this table so that when I position her, she doesn't feel like she's falling off. I do that with my body in the way. I basically block her knees with the crease of my groin, and I'm standing right here so she does not feel that she's falling off. So if she's too close to the edge of the table, she's never going to relax these muscles. So you have to have her well on the table, but you got to give her enough space so that I can get her feet off of the table. And that's very, very important. The only other thing I will mention is sometimes the IT band is really tender on the leg that's down on the treatment table, and you may actually have to put some padding in there. It's a little bit tougher on guys and people who are distance runners. One of the things you can do is just actually raise her legs up in my groin right here, right on the top of my thigh. I raise her up so I can slide her back and forth without any drag whatsoever. She'll really appreciate that if I'll make it as smooth as possible. And that's how to treat an ERSR. In our last example, we found that we had a vertebrae that was stuck in extension, and we had to flex it to fix it. And we found that we had a prominent transverse process on the right. This time, what we've got is a prominent transverse process on the right, and as the patient comes up on her elbows and rests her chin in her hands, that process gets even more prominent. It comes way up. What I know is the right process did what it was supposed to. The left one did not do what it was supposed to. In that case, I've got a segment over here on the left which is flexed, rotated, and side bent to the right. In order to fix it, I'm going to have to extend it, rotate it, and side bend it to the left. All right, so our cheat rule says put that toward the ceiling. She lies on her side with the dysfunction toward the ceiling. That's perfect. I'm going to take the top leg out of the way. I'm going to take the bottom leg and I'm going to extend it until I feel the barrier. Oh, there's my extension barrier, and I back off, and I just hook that up there for just a minute. Then what I do is sneak under and grab her shoulder, and I'm just going to slide her back. Oh, there's my barrier, and I back off. Okay? Now, I have to put a rotation barrier in because I got to close this down. So I rotate her to the left. Oh, there's my barrier, back off. And the last thing I do is I sit up on the table like so. Take the ankle and put side bending into it. There's my side bending right there. I tap her on the ankle and she pulls down with just a pound of pressure. Now, if you have a heavy leg, you might want to lean back a little bit so you don't have to use the forearm flexors. And that'll save you a lot of use and abuse over the years. 5, 4, 3, 2, 1. Release, take a deep breath. Down you go. I'm going to sneak this leg back. There's my new barrier. Oh, back off. Hand under the head. There you go. Good. I'm just going to push on her shoulder. Oh, there's my new barrier. Back off. I rotate her right on the front. Oh, new barrier. Back off. And then I come up here again. Introduce my side bending barrier just like that. Oh, there it is right there. Just a pound. She pulls right down to the table for 8, 7, 6, 5, 4, 3, 2, 1. Release. Take a nice deep breath. Good. And I'll do that 4 or 5 times and go back, and it will just correct that rotation beautifully. The last thing that we're going to talk about is lumbar mechanics that are neutral, what are called scolioses. And a scoliotic type 1 curve is multiple segments, and those multiple segments are 2 or more. And what you'll see and how they appear is as 2 or more rotated vertebrae all in the same direction. So in this case, I see a whole bunch of vertebrae on the left that are just way more toward the ceiling. So she's got a whole section right here that's actually rotated left, which also means by the laws of type 1 mechanics, she's side bent to the right. Well, in the lumbar spine, the problem is these side benders are the long iliocostallus lumborum and longissimus thoracis muscles, and they are taking multiple groups of vertebrae and side bending them all at once. And as they side bend one way, they rotate out from underneath the vertebrae above. So you get side bending, in this case to the right, rotation to the left. What we want to do is put the prominent transverse processes toward the ceiling. So here we go. She's going to lie on her side with these guys toward the ceiling. There you go, nice and relaxed. And what we have to do here is maintain neutral. When you find something that is a neutral type 1 mechanics, you have to keep it in neutral to fix it or you're not going to fix it. So I've got her flexed or extended. I'm not going to fix this on her. Neutral has to be treated in neutral. Type 1 must be treated in neutral. So what I've got to do is say, all right, where's neutral on her? All right, there's a little bit of flexion at the middle of the curve. You go to the middle of the curve. There's a little bit of extension. How about, oh, that's perfect. That's right in between. And I can do the same thing from above. I reach down under there and I say, all right, well, there, up. Now we're getting a little flexion. There's a little extension. That's perfect. I'm going to put my arm through here, but I'm not going to use it to rotate her. I want to keep her neutral. So I'm basically going to use it to control neutral. So I say, all right, that's rotated one way, that's rotated, where's neutral right there? And I hold her just like that. The last thing I'm going to do is side bend her. And I need to side bend her toward the left. So I'm going to sneak my legs under her legs. Pick her up like this and get both feet. Now slide this foot forward. There you go. Good. Perfect. Now she's resting. She's in neutral. And all I do is lean back. Now if you want to pick up both legs with your wrist flexors, be my guest, but they're not going to last long. Keep your finger at the apex of the curve. Lean back until you feel that first hint of movement. And you say, okay, pull down to the table. Now this one, because it is a type 1, you can give it a little bit more pressure, maybe 5 pounds if you want. If the scoliosis has been there for a long time, hold it for 30 seconds. Give it a little, it's a chronic, give it a little bit more help. And release and take a deep breath. Good, I maintain neutral. I go up, oh, there's my new barrier. Pull down, she pulls down with about 5 pounds of pressure, a little bit more if I was doing than I was doing single segment, and that's great. And 3, 2, 1, release, deep breath. Good. Keep her right where she is and just keep side bending her. And I would do that 4 or 5 times and go back and check my work. I cannot stress enough to straighten your elbow, lean back, and let your body mechanics do the work here. You're not going to be able to lift a lot of big legs. So do it like this and you won't get hurt. And down you go. And those are all the lumbar techniques that you need to learn. As a final thought, before you stop watching the video, I would like to express to you some very interesting points of view. You may be thinking, oh my goodness, I'll never be an expert I'm just a novice. It's going to take me so long to learn this material. I want you to remember something. I spent years figuring out the simplest ways to explain these things and really trying to get through a lot of the very confusing terminology and make it easy to understand. But a video can only do so much. So one of the things that I strongly recommend you do is take a muscle energy course. With me would be nice. And what you can do is go to the website that's at the bottom of your screen, www.tomoaklerpt.com, and click on the seminar link. And what it'll do is bring up all 4 of my courses that I am currently doing. You can check and see when the next one is going to be close to you, or if there's one that you want to travel to. I teach all over the country, and maybe you can find one close to you. And if you'd really like to have one in your location, then call me and we'll schedule one to do in your location. And as the last thought, you think that you're not going to be able to get good enough with this stuff, and you see me and you say, oh, he's just so good at this stuff. What's the difference between you as a novice, if you are a novice, and me as a more experienced clinician? I've made a lot more mistakes than you have. I had to make those mistakes to learn to do this. And if you are not willing to make mistakes, and if you don't want to sit there and feel a little fumbly at first with the patient, then you're lost. You won't be able to do it. You have to make the mistakes in order to get good. My database of mistakes is so much larger than yours. But the beauty with muscle energy is if you make a mistake, it doesn't come back to bite you. It won't hurt you. You're not going to hurt the patient. That's what's such a nice thing about muscle energy. So go out there tomorrow, start making your mistakes, start learning from what your hands tell you, and you will see your muscle energy career just skyrocket. Thanks for watching.